marche. Oui, le temps de...
Okay. Okay. Welcome to our plenary session of this afternoon, dedicated to COVID-19 pandemic. We are all concerned in the different European countries about COVID-19. And that's why we decided in the European Association of Hospital Managers to dedicate a specific session to this topic, so we can compare our experiences. It's very important to learn from each other. We will have speakers from the different countries, from France, Luxembourg, Italy, Ireland, UK, Greece, Hungary, Portugal, and Iceland. We will have three panel discussions. Before we start with these panel discussions, we will have two speakers who will speak about the history of epidemics. The two speakers are Philippe Blua, the General Director of the hospitals here in Troyes, Champagne Sud, and Professor Farouk Yalaoui, the Director of Research of the University of Technology in Troyes. They have slides in English, but they will speak French. And to all of you who are connected by video, you have the possibility to ask questions. Please do it in English, please. So now we can start with the first presentation. Philippe Blua and Farouk Yalaoui, you have the floor.
Thank you, Marc. Well, bonjour. Donc, je vais faire un petit et court résumé des grandes épidémies qui ont eu lieu. Une grosse partie de mon intervention sort d'un livre de Jean-Pierre Dedé, qui est un ancien chef de service à l'Institut Pasteur. Alors, un des points qu'il faut avoir en tête, c'est que la plupart des maladies, des grandes épidémies, ont une origine animale et avec un passage du virus de l'animal à l'homme. Et là, d'ailleurs, actuellement, ce que met en évidence la recherche, c'est que sur le plan épidémiologique, le passage à l'agriculture et à l'élevage était une catastrophe pour l'humanité parce qu'on s'est mis à fréquenter les animaux de plus en plus, à vivre auprès d'eux, et donc les possibilités de passage d'une espèce à l'autre ont augmenté, évidemment au détriment des humains qui sont retrouvés réceptacles, notamment des maladies que pouvaient avoir les animaux de basse-cour, mais ou d'animaux comme les rats qui hantaient les greniers, etc., et les maisons. Autre élément qu'il faut voir, c'est que l'origine des maladies, elle se répartit un petit peu partout, mais il y a quand même une concentration vers des départs vers le sud-est asiatique. Beaucoup sont partis de l'Inde et de la Chine. Dans l'histoire, ce sont des pays où il y avait depuis la nuit des temps une très forte population. Et donc, comme le facteur humain de transmission humain est très important, évidemment, quand vous avez des pays avec une forte population de paysans et en plus avec de fortes concentrations, l'émergence de nouvelles maladies dans ces pays s'en trouve facilitée. Donc, c'est un peu tout ce qu'on a, mais notamment les grippes, les principales épidémies de peste, le choléra, la variole viennent de là. a priori, c'est l'Europe, c'était plutôt le typhus. Et même les Amériques ont eu leur propre source. Parmi les principaux vecteurs de dissémination qu'on trouve, alors il y a beaucoup les parasites, notamment pour la peste et le typhus, le pouls et la puce. Le pouls, c'est plutôt le typhus, la puce, notamment la puce du rat, c'est plutôt la peste. Le moustique est un grand tueur. Tout le monde a peur des tigres et des requins, mais ça ne tue personne. Ce qui tue, c'est cette petite bête qui hante nos soirées d'été et qui est un des gros propagateurs de maladies. Et puis, l'autre grand propagateur des maladies, c'est la race humaine, évidemment, parce que toutes les interactions entre personnes, et c'est le sens des mesures actuelles, produisent forcément des passages de maladies des uns aux autres. Alors, en termes de vitesse de dissémination des épidémies, il y a 4 facteurs qui sont limitants et 3 facteurs qui, au contraire, accélèrent la dissémination. Et en fait, on trouve, c'est vraiment le cycle des facteurs qu'on trouve actuellement dans nos sociétés contemporaines. D'abord, l'augmentation de l'hygiène, c'est peut-être le facteur le plus limitant de dissémination. Si on veut sauver beaucoup de gens, il vaut mieux construire un réseau il vaut mieux prendre des mesures d'hygiène que construire des hôpitaux. L'accès aussi à l'eau courante et à une eau courante qui soit saine, c'est quelque chose qui est extrêmement important. L'invention des égouts et de la distribution de l'eau potable ont été 2 grands facteurs de baisse des épidémies. Les insecticides, on parle beaucoup de leur effet néfaste actuellement, mais quand même, l'éradication de la malaria dans une grande partie des zones habitées, et notamment en Europe, a été le produit des insecticides. Et puis, face aux grandes épidémies, c'est souvent la vaccination qui a été l'élément qui a permis de limiter leur impact. Et puis, on le verra plus tard avec quelques exemples. Et puis, il y a 3 facteurs qui augmentent la vitesse de diffusion d'épidémies. D'abord, l'augmentation de la population, c'est logique. Plus vous avez de porteurs potentiels, plus vous avez des chances que l'épidémie se diffuse. L'augmentation de l'urbanisation. On est au XXe siècle, et encore ça continue et ça augmente encore au XXIe siècle. Il y a une concentration de la population dans les zones urbaines et donc plus vous mettez les gens les uns auprès des autres, plus il y a des chances que la maladie se propage. C'est pas tout à fait un hasard si on trouve moins de malades du Covid actuellement dans la Creuse qu'en région parisienne ou à Marseille. Et puis le développement des transports. Dans toute l'histoire des épidémies, les épidémies ont suivi l'évolution ont suivi les routes commerciales, et c'est à travers les routes commerciales qu'elles se diffusaient de ville en ville, et notamment la marine avec le transport maritime a souvent joué un grand rôle dans l'apparition des épidémies, dans leur passage d'un pays à l'autre. Autre phénomène ce qu'on remarque d'ailleurs actuellement, c'est finalement les éléments qui limitent la dissémination ont été plus efficaces sur le nombre de patients et sur la mortalité que sur la rapidité de diffusion, parce que celle-ci, par contre, a plutôt tendance à augmenter. Vous voyez, ça, c'est une carte qui représente l'épidémie de peste du Moyen-Âge, qui a tué à peu près 30-50% de la population européenne. Elle était partie quelque part vers Samarcande en 1338 et elle a mis 14 années pour parcourir le monde à cette époque, en passant par l'Europe, où elle est arrivée vers 1347 et en revenant par la Russie. Donc, c'est des cycles très, très longs. Il a fallu 14 années pour parcourir au rythme des routes où on marchait à pied ou des routes où on naviguait à la voile pour faire le tour du monde. Quand on parle de la grippe espagnole, et ça c'est le point faible de l'augmentation du moteur, on commence à compter en mois. Il a fallu uniquement 16 mois entre 1918 et 1919 pour diffuser l'épidémie dans la plupart des pays, évidemment aidés par le retour des soldats qui avaient été envoyés sur les fronts en Europe. Et donc, finalement, là, les épidémies marchent au rythme des moteurs et c'est tout de suite beaucoup plus rapide. Et ce phénomène augmente encore avec le Covid. Là, l'avion s'y rajoute. Et en gros, entre le moment où on a identifié le virus à la toute fin de l'année 2019 et le moment où tous les pays ont été touchés, il s'est passé à peu près 3 mois. Donc, un temps très, très, très court. Alors, la particularité notamment du Covid, c'est que ça peut toucher toutes les classes sociales. Par contre, les épidémies qui sont liées à la pauvreté, elles n'ont pas vraiment progressé en vitesse. Là, vous avez sur ce slide l'exemple de l'épidémie de choléra qui a eu lieu au 19e siècle. En fait, elle a mis 11 ans pour parcourir le monde. Et le choléra, c'est une maladie qui est liée notamment au défaut d'assainissement, manque d'eau potable, problème d'hygiène avec le manque aussi d'assainissement des eaux. Et donc, vous voyez, c'est 11 ans pour que cette maladie parcourt le monde. Et il y a encore des épidémies de choléra. Évidemment, dans nos pays, on s'en rend très peu compte, mais il y a eu 3 vagues au siècle dernier. Et la durée de diffusion, elle partait toute du Bangladesh, et la durée de diffusion de ces vagues était assez longue, entre 12 et 22 ans. Sans doute parce que les personnes, le transfert de cette maladie est lié aussi aux conditions d'hygiène du pays où on va, et puis moins on a d'argent, moins on a tendance à prendre l'avion, à pouvoir se déplacer, etc., ce qui est un effet limitant. Les maladies liées à la pauvreté ont tendance, semble-t-il, en tout cas sur cet exemple, à se déplacer moins facilement que les autres. Et par contre, un élément qui est sûr, on le voit sur toute une série d'épidémies actuelles, c'est que la pauvreté, le défaut je l'ai dit, de possibilité d'avoir une vie, d'avoir l'accès à l'eau potable, de bénéficier d'un système d'assainissement des eaux, etc., entraîne aussi d'avoir un système de santé efficient, entraîne un nombre de patients très important. Vous voyez que le choléra, maintenant, plus c'est rouge, plus c'est prévalent. C'est vraiment lié à des problèmes de développement. Le gros point rouge côté Amérique, c'est Haïti. On trouve la même chose sur la malaria. Elle a disparu des pays européens où elle existait avant, jusqu'au début du XXe, mais elle se maintient beaucoup, notamment en Afrique et dans un certain nombre de pays où il y a des personnes pauvres. Là aussi, plus c'est rouge, plus il y a de prévalence. Le sida, c'est particulièrement sensible. C'est quelque chose qui est globalement contrôlé dans les pays développés, même s'il y a encore de nouveaux malades. Mais en Afrique, c'est une maladie qui est en train de prendre des proportions énormes et qui tue énormément de gens chaque année. Pareil, la syphilis qui avait ravagé l'Europe. Tout le monde a en tête au moins un des écrivains français qui a atteint de la syphilis au 19e siècle. Il y en a eu énormément. Maintenant, en Europe, elle a quasi disparu, mais c'est une maladie des pays en voie de développement. Alors là, une petite comparaison des différentes épidémies par nombre de morts. Alors, les chiffres sont forcément très variables, surtout pour les vieilles épidémies. Par exemple, là, je vous ai pris les chiffres les plus courants. Pour la grippe espagnole, on est entre 20 et 50 millions de morts. Il y a même des estimations actuelles, mais elles ne sont pas encore vraiment acceptées, qui parlent de 100 millions de morts. À comparer avec les pertes civiles et militaires de la guerre de 14-18, en fait, elle a tué au moins autant que la guerre de 14-18 et peut-être plus. Dans les pertes civiles, il y a notamment celles liées aux famines et aux autres maladies, pas à la grippe espagnole. Une grippe moderne, celle de Hong Kong, qui nous a touchés en 69, a finalement très peu tué par rapport, comme le Covid actuellement. Pour le moment, ça reste une maladie qui a relativement peu tué. Par contre, les grandes pestes ont été très importantes. Et le sida, alors le sida, c'est depuis le début de l'apparition, donc c'est un peu particulier parce que l'épidémie n'est pas finie, mais vous voyez qu'on est dans des chiffres qui, en tout cas pour les pestes et autres, correspondent aux grandes guerres mondiales. Ça, c'est le nombre de morts qu'on a actuellement pour les principales maladies qui peuvent décimer donc au XXIe siècle. La grippe, selon les années, ça tue entre 300 et 600 000 personnes. Le choléra, pareil, ça évolue, mais c'est devenu assez réduit désormais. Parfois, c'est moins de 100 000 personnes, certaines années, parfois ça monte plus. La malaria, ça a tendance à baisser, mais on est autour de 400 000 morts par an. Fièvre jaune, c'est devenu assez résiduel. Le sida, là, par contre, notamment en Afrique, c'est quelque chose qui se développe fortement. On en entend peu parler parce que on se sent peu concerné dans nos médias, mais c'est quelque chose qui devient très important dans certains pays. Alors, le Covid, les estimations, évidemment, c'est encore difficile. Les jeux ne sont pas faits. La plus haute estimation que j'ai trouvée, c'est 2,4 millions. Si on fait une règle de 3, on serait plutôt autour d'1,4 million. Mais ça montre que c'est vraiment pas une maladie à prendre à la légère. Actuellement, on est vraiment, enfin, l'année 2020 a été vraiment très impactée. Par contre, ce qui est intéressant, c'est de remettre le nombre de morts en lien avec l'importance de la population. Et là, on voit que depuis le 19e, on a vraiment quelque chose qui a bougé, c'est que les grandes épidémies du Moyen-Âge, de l'époque moderne, ça tuait des proportions énormes de la population. Et depuis le 19e, on est plutôt dans des pourcentages relativement raisonnables. La population a beaucoup augmenté. Les pestes, c'était entre 30 et 50% de la population qui mourait dans les zones qui étaient touchées. La variole et peut-être d'autres maladies intestinales qui ont été liées, ça a tué quasiment 90% de la population du Mexique, enfin de ce qui n'était pas encore le Mexique, qui allait le devenir au moment de l'arrivée des conquistadors. Le typhus, ça c'était lié à des attroupements, c'est beaucoup lié à l'histoire militaire, mais 20% de la grande armée qui est allée en Russie a été touchée et morte du virus. Souvent d'ailleurs dans les guerres, les maladies tuaient plus de soldats que les combats. Ça, c'est une grande constante de l'histoire. Mais voyez, toujours le même typhus, et pourtant Lénine avait dit que c'était le principal ennemi du communisme au moment de la guerre civile. Il n'a tué que 2%, c'est déjà énorme, mais il a tué finalement que 2% de la population russe, alors que c'était considéré comme quelque chose de terrible. Choléra, vous voyez, l'épidémie de 2,5% de la population parisienne, et puis on tombe maintenant dans des pourcentages qui sont extrêmement bas, parce que actuellement, par exemple, le Covid, et certes, il a tué beaucoup de gens, et il continue à tuer beaucoup de gens, mais à septembre, ça représentait 0,014% de la population mondiale, parce qu'on est quand même plus de 7 milliards à l'heure actuelle. Ce qui est important aussi, c'est de voir le traumatisme que peuvent créer ces épidémies qui ont parfois fait évoluer les mentalités de la société, notamment la grande épidémie du Moyen-Âge a contribué à l'accouchement de la Renaissance. Vous voyez, actuellement, en France, en septembre, on était à peu près à 31 000 morts. On a eu une journée, le 22 août 2014, pardon, 1914, pas 2014, excusez-moi pour cette petite erreur. Donc, pendant la guerre de 14-18, en une journée, on a perdu 27 000 soldats avec une moyenne d'âge de 27 ans. Ce qui, en termes de traumatisme, est énorme. L'Italie, pareil, il y a eu à peu près 36 000 morts jusqu'à présent avec le Covid. Et dans l'histoire romaine, la bataille sur une population qui était sans doute 10 fois moindre que la population actuelle de l'Italie, ils ont perdu 45 000 soldats tués lors d'une seule bataille. En Irlande, le nombre de morts actuellement par rapport au grand traumatisme qui a été la grande famine est extrêmement réduit. Aux États-Unis, par contre, le traumatisme va sans doute être important, puisque vous voyez que finalement, actuellement, le Covid a tué autant que la Seconde Guerre mondiale, plus je crois que la Première, et beaucoup plus que la guerre du Vietnam, qui a été pourtant extrêmement traumatisante pour la population américaine. Vous avez tous vu les films là-dessus. Une dernière slide sur le temps pour trouver les thérapies à partir du moment où on identifie le virus. n'y a pas vraiment de règles. Vous voyez, bon, le grand tournant, ça a été autour de 1900, mais il n'y a pas vraiment de règles, si ce n'est que, essentiellement, c'est le vaccin qui permet de lutter avant les traitements médicaux. C'est le vaccin qui a été le principal outil pour mettre fin aux grandes épidémies, en tout cas les rendre résiduelles. Et alors, il y a une exception, c'est la variole. C'est la seule maladie où finalement on a trouvé la solution avant de trouver le virus, avant de trouver l'origine, puisque la variole, dès le 16e siècle, en Chine, ils avaient créé une sorte de vaccin. On prenait du pus sur les pustules, les patients, on les grattait, et on avait même mis au point quelque chose qui ressemblait de façon très proche à la vaccination actuelle. Dès 1796, Napoléon l'a utilisé pour ses troupes, là aussi, qui allaient en Russie, alors que le virus, on l'a découvert qu'en 1904. Donc c'est, à ma connaissance, le seul cas où on trouve le vaccin avant d'identifier la maladie. Voici, c'était en quelques mots. Merci pour votre attention. Et donc, je passe la parole à Farouk Yalaoui.
Merci. Bonjour à toutes et à tous. Donc, on va essayer de continuer sur la lancée de la présentation que vient de faire, une excellente présentation de Philippe. C'est vraiment très intéressant. C'est à l'image de l'idée qu'on s'est faite quand on a réfléchi à cette présentation. Et on s'était posé la question, vous allez avoir un moment assez intéressant de partage d'expérience on est en pleine crise sanitaire, donc on s'est posé beaucoup de questions. On a interpellé, on cherche à réfléchir. On s'est dit, est-ce que dans l'histoire, il y avait des choses? Et là, Philippe vient de nous dire oui. Malheureusement, je pense même qu'il y en aura d'autres. Mais la question, c'est savoir comment s'y préparer. Et à cela, s'est posé la question, on parle beaucoup on est devenus tous experts. Pour certains, il s'est avéré, pour d'autres, télévisuels. Donc, sur des modèles un peu présentés. Vous avez vu, pour ceux qui ont été avec nous en début de conférence, il y avait une très, très belle présentation du professeur Christian Arabeau qui a vraiment montré un peu les derniers résultats avec une construction des modèles. Alors, je vous propose sur cette présentation que j'ai le plaisir de partager avec vous, un travail collectif avec une équipe, je vous parlerai à la fin. Donc, la question qu'il faut retenir sur ça, c'est qu'en 1960, on a commencé, l'homme est un relâchement, c'est naturel, de se dire, voilà, le système sanitaire se met en place, il y a beaucoup d'antibiotiques, les vaccinations sont là, normalement, il n'y a plus de problème avec le virus. Il y a une date, c'est assez marqué. Entre autres, vous voyez bien la référence. Cette présentation est à la base de plusieurs sources de références différentes. Donc, Hitchcock disait, voilà, à un moment donné, on s'était... Ensuite, mais il s'est avéré que finalement, c'est ce qui tue le plus. Comparativement à ce qui se passe par ailleurs, les virus, les épidémies tuent énormément. Et parce que c'est un agent, c'est une maladie qui évolue, qui s'adapte et sur lequel il faut vraiment travailler. Donc l'idée, ce qu'il faut retenir, que c'est l'humanité n'a jamais échappé aux épidémies et c'est pas fini. On parle d'exponentiel. Si je pouvais reprendre, c'est un travail fait par la WHO, la World Healthcare Organization. Ce qu'on vient de se dire se représente ici. Vous voyez bien une accélération, une réduction du temps d'arrivée des différentes épidémies du 13e, 14e siècle. Et vous voyez bien un peu entre le 19e et le 20e, il y a vraiment un nombre d'épidémies, nombre de virus différents. Philippe, lui, vous les a présentés, qui sont de plus en plus nombreux. Parce qu'il y a une théorie sur ça qui dit que le virus aime bien voyager. Il y a une association à la machinerie. On s'en parlait ce matin. Dès que la mécanisation a été mise en place ou adoptée, en 1889, 1890, le train étant là, donc ça a voyagé par le train. Et 1980, l'arrivée avec l'avion, ça a accéléré. Il faut savoir aussi, je voulais revenir sur la notion de la quarantaine parce que ça date bien plus tôt. C'est les navires qui arrivaient au niveau des ports et qu'on mettait en réserve et on mettait en isolement pendant 40 jours ces marins. Il y a eu des histoires dans certaines villes, dans Marseille, où les gens n'ont pas respecté ça et ça a généré certains drames, mais bien d'autres villes comme Venise. L'objet de ma discussion, c'est pour reprendre un peu cette synthèse historique qui est capitale, c'est pour revenir qu'au final, également pour les méthodes utilisées, il existe une histoire d'évolution des modèles qui cherchent à les représenter. C'est un peu de formule, c'est histoire de vous dire qu'on est à l'Université de technologie, une conférence où il y a de la formulation mathématique. Mais l'idée, c'est surtout de se dire, ça remonte à très loin. Et les modèles, on n'a pas fait mieux. On a amélioré, on a mieux performé, mais on n'a pas fait mieux que ce qui a été proposé par Bernoulli en 1760. C'est le premier modèle épidémiologique connu et qui a écrit une formulation très, très simple entre les cas susceptibles d'être affectés par un virus et les cas immunisés. Et il a décomposé ça en fonction de l'âge, en identifiant l'âge, la catégorie susceptible de survivre à l'infection, la probabilité de la population susceptible de mourir de l'infection, lambda étant la force d'infection, mu de A étant le taux de mort. Je vous rappelle simplement ça pour que vous puissiez visualiser qu'on peut être immunisé et mourir, il y a un taux, vous l'avez à droite. Inversement aussi, en étant susceptible, on peut également un taux de mortalité qui est du même ratio, auquel s'ajoute ce qui est dû à l'infection, à l'épidémie. Et tout le travail, c'est de savoir un peu comment on immunise le fameux SA fois lambda A. Donc tout le travail qui s'est articulé sur une formulation comme ça, et par des observations, des statistiques, on a essayé d'écrire, de représenter mathématiquement ce comportement-là. Et il s'est avéré très, très robuste. On se base encore. L'autre acte fort sur les réflexions, sur l'apport des mathématiques, de la représentation, on appelle actuellement de l'intelligence artificielle, mais il y avait déjà avant l'intelligence artificielle l'intelligence tout court, c'est ce que je vous présente ici, et c'est les modèles mathématiques. C'est le travail qui a été fait sur le choléra par John Snow et qui a pensé qu'il y avait un lien entre les sources d'eau, ou l'eau, et les lieux d'infection et les lieux de choléra. Il a essayé de représenter tout ça sur une carte. Il a, grâce à ce rapprochement-là, retrouvé que tout ça est dû, je ne sais pas si ça se voit, non, ça ne se voit pas. Tout ça est dû à une fontaine bien précise et que le taux de mortalité autour de ce point était nettement plus important. Donc, il y avait une corrélation, un lien établi entre le niveau de mortalité, la source de la mortalité, pour faire ça. Qui a donné par la suite une idée très importante qu'il y a un lien entre l'évolution d'infection, la mortalité, et le temps. C'est le travaux qui ont été faits juste au début du siècle, 1906. Vous voyez que ça remonte peut-être à loin, mais c'est les modèles qui sont très, très, très efficaces, qui le restent toujours. Donc, il y a trois grands groupes. Le groupe I, c'est le groupe dit des individus affectés qui deviennent contagieux, et le groupe S, qui sont probablement affectés par cette maladie, par le virus. Et N, on le note comme la totalité. Il a établi, ça c'est un vrai travail intéressant, qu'il y a le fameux DI sur DT veut dire l'évolution de ce nombre de personnes infectées divisé, ramené au temps nécessaire par rapport au temps. Il est inversement en relation, ce rapport-là entre le nombre de personnes probablement affectées ramené au temps. Donc cette relation-là qui a l'air toute simple, mais qui est fondamentale pour comprendre un peu la relation sur ces deux cohortes, ces deux groupes de population, si on devait ramener une population générale. Ensuite, il a établi qu'il y avait une fonction qui pouvait le représenter mathématiquement et que cette fonction, c'est tout simplement B, bêta fois S fois I. C'est vraiment ce qui rend ces modèles-là éminemment surprenants. Leurs comportements sont peut-être complexes, vous le verrez, c'est une des conclusions, mais d'une formulation simple. Donc, vous voyez bien, au final, entre un cas susceptible et un cas affecté, et pour peu qu'on considère un bêta de taux de transmission, d'où toute cette agitation de compréhension rapide mais difficile à maîtriser, que c'est ce fameux bêta qui régule parce que la relation en elle-même de comportement, elle est simple. Donc, le rapport d'évolution de la population des individus contagieux est égal à bêta fois S fois I. Donc, on l'écrit de manière simple, c'est une simple multiplication. Et inversement, c'est la population susceptible d'être affectée est égale à moins cette relation-là. Dès qu'on a compris ça, donc on est en capacité de le représenter. Et c'est tellement vrai que ces résultats-là ont donné lieu à un beau travail d'un grand monsieur. Tous les grands chercheurs ne sont pas connus, mais je vous le concède aussi parce que j'ai découvert ces travaux pas très longtemps. C'est un prix Nobel 1902, Ronald Ross, qui a travaillé sur les moustiques, et même son théorème sur les moustiques, et qui a essayé de trouver un lien, comment en réduisant le nombre de moustiques dans un endroit, la corrélation de ça, on pouvait réduire une maladie qu'il a démontré qui était associée à ça. Et donc, il a mis là, ce qu'il a appelé la pathométrie, c'est-à-dire l'association par rapport à un pathogène et de suivre ses calculs, son comportement, et de voir un peu l'impact de l'affection d'un individu, son lien par rapport à sa communauté, et ensuite de suivre cette estimation-là dans le temps. D'où toute la théorie actuelle qui a l'air élémentaire mais qui est fondamentale, l'isolement, l'impact sur la communauté, la transmission, parce que, y compris mathématiquement, ça a un sens et que ce n'est pas à défaut de solution au sens médical qui est une vérité, mais aussi ça a un sens aussi sur les impacts. Donc je vous renvoie aussi toujours en termes très récents ce qu'il a appelé le professeur Rabot hier le modèle de Pasteur avec le fameux R0, donc je parlais juste après. Parce que le R0, il ne date pas d'aujourd'hui. On a l'impression de découvrir, il date de 1925. Donc c'est Alfred Lotka qui l'a mis en place. Et c'est the average number of a parent contagious can affect. C'est le nombre de personnes qu'une personne affectée peut pas affecter. Vous le voyez bien, je ne sais pas, oui, c'est assez visible sur la projection. Vous voyez bien que les ratios sont différents en fonction des types entre le MERS, l'influenza, l'Ebola. Le Covid, là, c'est un travail de Giallo Viconte qu'il a publié en février 2020. À l'époque, on était à 2,5. Là, on est un peu moins, mais je ne sais pas exactement le taux actuel. Le SRAS, le SARS, qui était à 3,5 et jusqu'à des infections un peu plus, de 16, qui est vraiment assez contaminant. Et la réflexion qu'il a faite était importante sur ce ratio de transmission, cet impact de l'individu porteur sur le premier modèle de Bernoulli qui dit oui, il y a un taux et cette représentation est facile. Il s'est dit, si on pousse plus loin, ça peut avoir un sens. Ça peut faire mal aux yeux pour ceux qui n'aiment pas les formules mathématiques. L'idée, ce n'est pas vous faire mal, mais c'est surtout de vous montrer qu'il y a un lien. Et c'est cette belle slide. Tout va bien, j'ai toujours tout le monde. Donc, l'idée, c'est surtout d'avoir que l'évolution, ce qu'il faut lire sur ça, c'est que l'évolution dans le temps de la composante S, donc c'est ça ce que ça veut dire, ds sur dt veut dire l'évolution de la population S par rapport au temps, est égal à moins lambda, le fameux taux de contamination fois la taille de la population. Ce qu'il faut surtout regarder, c'est la partie droite, entre les fameuses relations entre les susceptibles d'être infectés, les infectés et tout ce qui disparaît dans un sens ou dans l'autre. Et on a ajouté au bêta, le fameux taux de transmission, le fameux taux de recouvrement, le meilleur, donc d'aller mieux, de guérison par rapport à ça. Et le travail qui a été fait par ces deux grands chercheurs, et les modèles actuels, qu'on les appelle Pasteur ou tout autre, ce sont le fameux modèle CIR qu'on utilise encore très, très largement. C'est Karma qui l'avait lancé avec McKendrick en 1927 et sur lequel tous ces calculs-là sont basés. Et on a simplement essayé maintenant de le trouver, les paramètres qui les font varier. Vous le voyez bien, sur DS sur DT, c'est une relation, DI sur DT, c'est une relation, DR sur DT, c'est une autre relation. Sur simplement toujours deux paramètres fondamentaux, taux de transmission et taux de guérison. Et on a pu vous retrouver un peu les fameuses courbes qui commencent à devenir un peu même connues. C'est un peu la représentation, le pic, la décroissance en fonction des différentes populations. Là, je ne voulais pas être long, je pense qu'on va y arriver pour respecter, je ne sais pas, le temps, on doit être dans le timing. Je reprends, c'est que les modèles mathématiques sont devenus un outil important. Je reviens à la notion de modèle mathématique parce que je pense qu'ils sont aussi fondamentaux que ce qu'on appelle la data actuellement, ce qu'on appelle l'intelligence artificielle. C'est que l'idée, voilà, on veut manipuler un nombre de data assez important, mais l'idée surtout, c'est d'être en capacité de représenter. Et certaines représentations s'appuient sur des représentations très simples. Ce qui est important aussi, c'est de pouvoir comprendre. Et comprendre sur une approche dite parcimonique, c'est-à-dire juste ce qu'il faut de représentation pour ne pas non plus les compliquer. Et l'épidémiological modeling, la représentation ou la modélisation épidémiologique, permet quoi? D'avoir une représentation, une analyse générale, donc un survey, une représentation, d'avoir une analyse des data et les data les plus pertinentes. Ça ne sert absolument à rien de garder toutes les data, et d'identifier les tendances, identifying trends qui sont là. Beau travail qui a été fait tout récemment également, c'est par Martin Hersink, sur lequel il faut travailler. Et je me permets de prendre la feuille pour la traduction de la phrase parce que je l'ai traduit en français pour être sûr que je ne... Voilà. Donc la traduction exacte, c'est même si vous l'avez, in fact, the whole epidemiology, mais on va le faire en français. En effet, toute l'épidémiologie doit être considérée mathématiquement. Cependant, nombreuses variables sont impliquées. Donc, je veux dire, et dire qu'une maladie dépend de certains facteurs ne signifie pas grand-chose jusqu'à ce que nous puissions également former une estimation de la façon dont chaque facteur influence en grande partie le résultat global. Donc, ça a été dit par Ross, prix Nobel 1902. Donc, l'idée, c'est de dire, oui, il y a peut-être des paramètres compliqués, nombreux, mais il faut aller chercher celui qui le juste paramètre correspondant à l'évolution du phénomène, en particulier par rapport à l'épidémie. Voilà. Donc, il y a énormément de modèles actuellement qui sont de plus en plus riches, de plus en plus nombreux, et qui est sur le niveau de paramétrage. Et plus on est riche en data, plus les modèles sont affinés. Je vais simplement terminer ma présentation en remerciant toute l'équipe qui a été impliquée sur ça. Yassine Ouazen, Nguyen Cui, qui a vraiment beaucoup travaillé avec moi sur la recherche sur ces-là. Paulin Cousin aussi et Elnaz, qui sont vraiment impliqués énormément sur ça. Merci aussi à l'équipe de la chaire et de la capacité qu'ils nous ont donné de pouvoir organiser l'événement et de continuer à travailler sur ces modèles. Et si vous avez besoin de quelques lectures, il y a quelques livres disponibles, un peu, mais ils ne sont pas tous, et sur la santé également, n'est-ce pas Philippe? Voilà, sur ce, je vous remercie et je suis à votre écoute. Si vous avez des questions dans la salle, je laisse Marc s'il veut bien reprendre. Merci à vous.
Okay. Do you have questions? Y a-t-il des questions dans la salle? Respectively, have we any questions from the people who are online? Do we have information about people who are connected? Not for the moment. Yeah. OK. Alors, dans la salle, y a-t-il des questions? Vous les posez en français, comme vous voulez. Hein. Moi, j'aurais une question. Donc, là, il y aura certainement encore beaucoup d'études par rapport au modèle à considérer pour comment dire, les études d'évolution des différentes épidémies. Concernant la Covid, quels sont les risques maintenant que nous assistions à une accélération du taux de contamination et de dissémination?
La réponse peut être multiple. Il me dit c'est une réponse de mathématicien. Peut-être pas. C'est peut-être une réponse de praticien de la santé. Mais c'est une réponse de tous. Si je me réfère ne serait-ce qu'à ce qui a été dit hier, est-ce que tout le monde est d'accord? Tout est possible mathématiquement, c'est des rapports, donc le comportement, la convergence est possible. Donc toute l'intuition qu'il y a eu, qui a été formalisée sur des taux qu'il faut réduire au-dessous d'un certain seuil, donc là on parle de gestes, on parle de tout ça, ça peut que contenir et donner des limites à cette évolution possible.
Juste pour compléter, par rapport aux autres épidémies, on voit que bon, le Covid, maintenant, la propagation, c'est d'humain à d'humain. Donc, le vrai enjeu, c'est vraiment ce dont il est question actuellement partout. C'est la prudence dans les contacts humains et la capacité à bien respecter des règles d'hygiène pour créer des barrières dans les échanges entre individus. Et c'est de là que dépendra en grande partie la réussite ou l'échec de la lutte contre la maladie. En attendant le vaccin ou l'éventuel médicament qui pourrait rompre vraiment. Mais tant qu'ils ne sont pas là, ça va être la seule solution, c'est d'être prudent.
So it's very difficult because we have a lot of factors influencing the evolution of the pandemic. It's not easy to say exactly if it will go on in a faster way. But that's one thing we are sure, that we have to protect ourselves, and that's, of course, the most important for the moment.
The social distanciation, you have to make distance between people.
Yeah, distancing with people. Yeah, okay. I propose now to You have a question? No?
Merci pour... vous m'entendez bien, oui? Merci pour ces deux excellents exposés. Moi, j'avais une question sur les personnes qui ont travaillé sur ces travaux et de quel domaine ils étaient, de quelles compétences plus, et quelle était l'évolution justement des personnes jusqu'à l'heure actuelle qui travaillent sur ces modèles de prévision. Est-ce que c'est plus statisticien, médecine, sans les opposer, ou est-ce que vous avez une réponse à apporter dessus?
Oui, c'est bon. Sur l'aspect curatif, ça a été forcément les médecins qui ont été, enfin, pour trouver, analyser, même si Pasteur n'était pas médecin. Hein. C'était un biologiste. Si je enfin, et au départ, il avait travaillé plutôt sur des éléments vétérinaires autres. En tout cas, c'était pas du tout un médecin, mais évidemment, sur la plupart des pathologies, ce sont les médecins pour la partie curative. Pour la partie étude et recherche, là, je passe la main à...
Mais on le voit bien sur le premier modèle. Bernoulli, ma connaissance, n'est pas médecin. Donc, c'est un statisticien, mathématicien qui a travaillé dessus, qui a fourni beaucoup de modèles assez robustes. Mais il est évident, et ça c'est une vraie évolution qui est assez intéressante, c'est plus la rigueur scientifique m'oblige à non pas en faire une généralité ni une affirmation, parce que je n'ai pas fait d'études dessus, mais l'intuition c'est qu'il y a une vraie convergence qui sont en train de s'installer sur des spécialistes de métiers qui s'intéressent à des sciences des mathématiques parce qu'ils se dotent de formation. On voit beaucoup de médecins, on a vu l'exemple hier et bien d'autres, mais on les voit, c'est des médecins qui s'intéressent avec un bagage mathématiques et statistiques, mais avec tous ces avantages évidemment, mais ça peut aussi nuire parce que ça introduit ce qu'on appelle des expertises métiers. Alors parfois il va y avoir des outils un peu muets, type mathématiques dur, pur et dur, et les comparer. Je pense que actuellement les modèles se développent parce qu'il y a une vraie communication entre les entités de l'INSERM où ils font des mathématiques, où ils font aussi des biologies. On le voit aussi dans l'agriculture, hein. Les centres de recherche, pour parler de recherche français, sont ça, quoi. Donc, je vais laisser Marc traduire ou je peux traduire comme il veut. I just saying that Bernoulli, he's well known from statistical side. He's a well-known researcher about that. He established many rules, many law distribution. And right now, we are having like a trend that many medicine doctors are trying to work using statistics, like Ross, and making like pathology process. And based on that, there is a new trend that many people from their own experience trying to attract from mathematics side more background, more skills, and to make modeling and make a response about that. And I think that in the future, something could be a hybrid process between people from the real life, from the specialization system, and the mathematician. But it's something is between. I would say even in English that in university, maybe I have to guess and to establish something new, some new degrees of people with hybrid skills.
Je crois que ce sera la dernière question parce qu'autrement, on ne va pas respecter le timing. Hein.
Merci pour cette perspective historique et ces deux présentations. J'ai mis une question. Est-ce que vous avez une idée, après l'analyse, de se dire comment une formule aussi simple tienne depuis un siècle? Est-ce que la pandémie, en fait, finalement, les pandémies ne sont pas aussi complexes que ça? C'est en termes de phénomènes à gérer.
Est-ce que, comment dirais-je, est-ce que si le modèle mathématique est simple, est-ce que c'est plus facile à gérer ensuite en termes d'action? Je ne suis pas sûr, parce que ça dépend de la difficulté à traiter. Donc là, je crois que c'est quand même deux choses qui est assez difficile de lier. On voit d'ailleurs que par rapport au délai entre le moment où on trouve le virus et le moment où on trouve la solution, il n'y a aucune règle il n'y a pas de phénomène d'accélération. Normalement, plus on va dans le temps, puisqu'on est maintenant, on a plus de connaissances, etc., que dans le passé, on devrait aller beaucoup plus vite. Or, on a vu que, par exemple, sur le sida, on n'allait pas beaucoup plus, on avait même été moins vite que pour certaines autres pathologies qu'on avait découvertes au début du siècle pour être efficace. Donc, voilà, entre le moment de la compréhension du phénomène et trouver la solution, il n'y a pas forcément de lien évident.
J'ai peut-être un complément de réponse à ça. En école d'ingénieur, E égale mc carré, quoi. La dérivée de l'énergie vaut l'énergie totale est égale à l'énergie, à la masse, la dérivée de la masse multipliée par l'énergie. Donc, tous les phénomènes énormes, E égale mc carré, c'est la démonstration de l'énergie par rapport à l'atome, avec tout ce que ça a généré comme processus pour créer des bombes atomiques et tout ça. Un modèle simple ne veut surtout pas dire que le processus est simple. C'est au contraire, c'est que on est en capacité de le structurer de manière un peu intelligente. Et je suis même de l'école de la parcimonie, c'est-à-dire quand on cherche à en faire trop, c'est qu'on n'est pas en capacité vraiment d'avoir trouvé la quintessence du modèle. Donc c'est pour ça que quand on écrit des modèles pas possibles, on le sait, quand on fait beaucoup de modèles informatiques, c'est qu'on ne sait pas écrire analytiquement. Quand on ne sait pas écrire analytiquement, c'est qu'on n'a pas tout compris. Et donc quand c'est simple, c'est comme ça. Donc c'est radical, mais c'est comme ça, c'est mon point de vue. Donc le fait de l'avoir simple, c'est qu'on a quand même la maîtrise, il tient depuis un siècle. Peut-être on fera mieux, mais voilà. Donc la simplicité ne veut pas dire que c'est facile.
Oui, encore une. Okay, can you read the question?
This is a question from Mrs. Louise McMahon. All of these pandemics starkly illustrate the importance of the behaviors of individuals in protecting their own health and that of the rest of the populations. Have populations become too dependent on medicine, drug treatment, vaccines? Do pandemics change behavior?
J'ai pas entendu avec le masque, je suis désolé.
Sinon, je vais le mettre en.
Projet de la question.
If not, I can make. I can give Miss Louise McMahon the microphone. Then she can ask directly in by her microphone. So please, your parole is yours, Miss Louise McMahon.
Can you hear me? Good afternoon.
Noon. Please ask your question, Louise. Thank you.
Can you hear me?
Yes, we can.
Okay. Yes. Thank you for two excellent presentations. So all of our current experience and history shows the importance of our individual behavior in protecting our own health and that of the rest of our communities. Have populations become too dependent on medicine, drug treatments and vaccines? And do pandemics change public behavior?
Yes, I'm not sure we are more dependent, but as soon as we find therapies that resolve problem of one epidemics, we think that there is no more problem, and we forget the essential things is hygiene. and for example, it was very interesting when AIDS appears, because it was my beginning in the hospital, and people who are working in hospital think with antibiotics there is no more problem of infection, because the antibiotic resolve a lot of problem of infection, and we come back to have, after AIDS, to have water and soap in hospital and hydroalcoholic solution, because we discover one more time, and I think we are doing the same times now with COVID, we discover one more time that hygienic tools are the best against epidemics. Juste pour résumer, je disais que en fait, à chaque fois qu'on a des thérapies qui deviennent efficaces et que du coup on arrive à vaincre les maladies, on oublie finalement l'intérêt de l'hygiène, et souvent les grandes épidémies, ça nous ramène à cet intérêt-là, comme le sida, ça a réappris dans les hôpitaux à se laver les mains, alors qu'avant on comptait sur les antibiotiques pour résoudre toutes les infections.
Thank you, Louise, and thank you to Professor Yalaoui and to Philippe Blua. So now we have We can start with our first discussion, our first panel. Our online invitee is Professor Ugo Luigi Aparo. And Professor Aparo is one of the main actors of the Hospital and Clinical Risk Managers Association from Italy. Italy was severely affected by the first wave of COVID-19 at the end of the last winter. So it's particularly interesting to have a feedback from Professor Aparo about the situation in Italy during the first months of 2020. Professor Aparo, your country was hardly impacted, but first, before we start discussing about what are the experiences, what you learned about the COVID epidemic, could you please say in a few words what is the situation today in Italy, respectively, the most important things to know about what you lived in, what happened in Italy in the first months of 2020? We don't hear you. We have a problem with the sound. Could you please connect the switch on the sound?
Do you hear us? Non, non, c'est moi ça. Je parle accent italien. Mais, il vaut mieux déconnecter, reconnecter, c'est peut-être avec lui. Ouais, sinon le rappeler. Vous avez fait les essais? micro, on l'aura. C'est possible. Quitte à ce qu'on le rappelle, c'est ce qu'on veut. Ah, sinon, on peut utiliser au téléphone. Ok. Sinon, je laisse la parole. Oui. Ok. Ok.
Propose we can start with another country and we will later come back to Italy.
Écoutez maintenant.
Ça fonctionne.
Vous êtes en train de m'écouter maintenant?
Ok. Ok. Professeur Aparo, ok, the floor is yours.
Ça fonctionne maintenant?
Ça fonctionne.
Bon, alors j'ai changé de computer, voilà. C'est plus simple.
Ok, so you can speak, please.
Merci. Alors, un bon après-midi à tous. Et oui, j'ai reçu la question. Donc, c'est une sorte de comparaison entre les premiers mois de cette année et ce qui est en train d'arriver maintenant. Allô?
Yeah.
Alors, la question,
could you speak in English? Is it possible? Or if you prefer to speak French, you can speak French. Yeah.
Ouais. Alors, je disais, la question, c'était de qu'est-ce qui était arrivé au premier mois de cette année et qu'est-ce qui est en train de se passer maintenant, c'est ça?
Oui, et avant tout, quelle est actuellement la situation aujourd'hui en Italie par rapport à ce qui s'était passé en début d'année?
Bon, alors, la situation est très différente en ce moment parce qu'au premier mois de l'année, nous avons eu une situation absolument, une nouvelle situation. On n'avait jamais vu une chose pareille et sûrement, on n'était pas préparé à ce qui était en train d'arriver. Donc, il y a eu aussi des problèmes. Je me souviens que les premiers temps, on disait que, pour faire un exemple, que les masques chirurgicaux n'étaient pas importants de les utiliser. Voilà. Et puis, les choses ont très vite changé. Mais la vérité, c'était que les masques chirurgicaux, on n'en avait pas. Et il n'y avait pas de dispositifs de protection individuelle. Et donc, la seule chose qu'on pouvait faire, c'était de faire une correcte hygiénisation, surtout des mains, et de maintenir les distances. On ne savait pas bien rien de ce virus. On savait très peu aussi de la thérapie qu'on pouvait utiliser. Et donc, et puis, les malades étaient surtout des malades fragiles, des personnes très anciennes. Et donc, on a eu aussi un temps très élevé de mortalité. Puis, avec le lockdown, la situation du pays a beaucoup amélioré. On a pu, et surtout, on n'a pas eu plus de problèmes de capacité des hôpitaux de répondre à l'émergence. Et puis, vers la moitié du mois de mai, on a terminé le lockdown. Et là, quelques problèmes ont commencé parce que les gens ont commencé, et pas seulement les gens, à penser que le pire était passé et que donc on pouvait très bien baisser la garde. Ce n'était pas exactement comme ça, mais l'été a beaucoup aidé sur le fait que le virus était, au moins semblait être moins mauvais. Il y avait moins de malades très importants et les thérapies intensives ont diminué se sont presque vidés. Et puis maintenant, on a une situation comme je vois qu'il y a aussi dans les autres pays, on a eu moins de cas chaque jour nouveau, mais changer aussi la capacité de les rechercher. Donc aujourd'hui, on fait des tampons, beaucoup de tampons qu'on ne faisait pas auparavant. On a la capacité de faire des tampons rapides. Maintenant, on commence avec les tampons salivaires. Donc, un tas d'autres possibilités de rechercher le virus. On a aussi la sérologie qui n'est pas beaucoup, disons, dont les résultats sont toujours peu affidables, on peut dire, mais avec un virus dont on savait très peu, même aujourd'hui on sait beaucoup plus, mais je pense que ce ne sont plus les choses qu'on ne sait pas de ce virus, de ce que maintenant nous connaissons. C'est un virus aussi qui a changé beaucoup des choses qu'on avait appris et sur lesquelles on était sûr. Je fais un exemple. C'est dès l'université qu'on a appris qu'il y a les immunoglobulines M et puis après les G. Eh bien, on a vu un tas de cas de malades de COVID qui ont eu les G bien auparavant que les M. Donc, vraiment des choses très différentes de ce que nous avons et on était habitués à connaître. Et hier, nous avons eu 2500 nouveaux positifs de Covid en Italie. Ça a été le numéro le plus haut depuis beaucoup de temps. Dans ces derniers jours, dans la deuxième moitié de septembre, on était entre 1200 et 1800 positifs par jour. Je dis positif parce que positif, ça ne veut pas dire malade. Les malades qui sont en train d'être soignés dans les hôpitaux, bien sûr, ont maintenant aussi bien augmenté. Mais ce qui est très important, c'est que bien qu'il y a une augmentation aussi des thérapies intensives, jusqu'ici, c'est une augmentation absolument qu'on peut contrôler très facilement. C'est comme beaucoup ont l'impression que le virus soit moins agressif, moins mauvais qu'auparavant. On ne peut pas dire ça. On ne peut pas savoir si ça c'est vrai. On ne peut pas savoir si maintenant on est capable de comprendre, de nous apercevoir le virus plus tôt et donc de permettre qu'on n'arrive pas à la situation qu'il y avait auparavant. Aujourd'hui, on a une intégration entre les hôpitaux et les territoires qui était complètement absent dans les premiers mois de l'année. Et donc, ce sera seulement les prochains temps qu'on pourra savoir si c'est vraiment une diminution de cette agressivité du virus ou bien si c'est nous qui sommes capables maintenant de le combattre mieux. Il y a bien sûr le problème maintenant de la grippe. Et donc, le gouvernement a rendu maintenant obligatoire de faire la vaccination pour la grippe pour tous les gens qui ont 60 ans, âgés plus de 60 ans. Apparemment, c'était 65, maintenant ils ont porté à 60 ans. Parce que, bien sûr, il faut dire que les symptômes sont très semblables. Et donc, peut-être la seule chose qu'on a toujours dans le Covid, c'est la fièvre. Et il y a beaucoup de ces formes de grippe qui n'ont pas de fièvre, mais c'est très peu pour pouvoir faire vraiment une diagnostic différentiel. Donc, c'est très important que les gens se vaccinent. Comme ça, on peut avoir disons, moins de cas de difficulté de comprendre ce que nous devons affronter. Donc, c'est une situation en Italie absolument contrôlée maintenant. Mais c'était aussi une situation où il faut faire beaucoup d'attention. Hier, à Rome, ont à nouveau rendu obligatoire l'utilisation de la masque chirurgicale aussi au dehors. Auparavant, on n'était pas obligé de mettre la masque chirurgicale au dehors de la maison, seulement lorsqu'il y avait des assombремents ou des risques de ne pouvoir pas tenir un mètre de distance. Hier, la région Lazio a obligé à l'utiliser. Bien sûr, l'été a créé beaucoup de problèmes avec l'ouverture des discothèques, etc. Mais ce que nous sommes en train d'attendre, et il faudra attendre encore, disons, 10 jours, 15 jours, c'est voir les premiers résultats de l'ouverture des écoles. On a rouvert l'école et bien sûr, ça aura sûrement un effet d'augmentation du Covid. Combien, ça, on va le voir. Et si maintenant, on a beaucoup plus de cas positifs de Covid, par exemple en France, en Angleterre, etc. Et ça, ce n'est pas parce que quelqu'un est plus capable des autres, mais simplement parce que nous avons ouvert plus tard les écoles et donc on doit encore attendre pour comprendre bien si nous aurons les mêmes numéros de positifs que les autres pays ou bien si les comportements des Italiens qui sûrement ont bien compris et dont je pense qu'au moins le 90% de la population italienne est en train de se comporter très correctement, sera capable de ne pas faire augmenter trop les nouveaux cas de Covid. Voilà, ça c'est une première...
Okay, thank you, Professor Aparo. So I want to resume. The situation in Italy is under control. Of course, nowadays you know more about COVID than in the beginning of the year, but there are a lot of things we don't know. We have to take care what's about the evolution of the pandemic. It's not finished, and of course we have to take care. I have a question. What will change on your mind on the level of hospital management after the experience of COVID, after the last months?
C'est une belle question. Il y a beaucoup de choses sur lesquelles on doit réfléchir. La première chose très intéressante, c'est que toutes les autres infections hospitalières ont beaucoup diminué dans ces périodes. Et ça, ce sera une chose dont on devra bien comprendre, réfléchir. Parce que ça signifie beaucoup si elles sont diminuées. Ça veut dire que on ne fait pas assez d'attention sur les comportements individuels dans les hôpitaux. Ça a été une première leçon. Et la deuxième, c'est le Covid est une chose très particulière parce que Et il nous a obligés à changer, à faire quelque chose, une sorte de violence de management. C'est-à-dire qu'un système complexe comme est l'hôpital doit être géré maintenant comme s'il n'était pas un système complexe, comme si on pouvait le fragmenter en pièces détachées et que chaque pièce puisse fonctionner presque en manière d'autonomie. Parce que ce qui est très important, c'est d'éviter le plus possible qu'il y ait des passages de malades, mais aussi de personnel entre une unité opérative et une autre unité opérative. Donc, les parcours de l'hôpital, les activités de l'hôpital, on a dû complètement les repenser et il faudra aussi, lorsque tout sera terminé, penser combien de ces changements qu'on a faits puissent même rester aussi après le COVID. En ce moment, je peux seulement vous dire qu'est-ce qu'on est en train de faire dans mon hôpital. C'est un hôpital de réhabilitation. Alors, un malade, pour entrer dans l'hôpital, doit avoir un tampon qui est négatif dans les dernières 48 heures. Lorsqu'il arrive dans l'hôpital, dans l'acceptation de l'hôpital, excusez-moi, mais ce n'est pas du Covid, parce que je fais un tampon hier après-midi et je suis négatif. Et il fait un tampon rapide. Puis, il entre dans son unité opérative, il va dans une chambre tout seul et il reste dans cette chambre 7 jours dans ce que nous appelons une observation précautionnelle. Donc il ne sort pas de cette chambre, il est soigné bien sûr, et il ne peut pas recevoir des visites de ses familiaires. Et après les 7 jours, il fait un nouveau tampon. Si le tampon est négatif, alors il entre dans les activités normales de l'hôpital et il peut aussi aller dans une chambre avec un autre malade. Puis, chaque fois qu'il a un minimum de fièvre ou quelque chose qui puisse faire suspecter quelque chose, il fait tout de suite un tampon rapide et puis le jour après, un tampon normal. Et lorsqu'il sort de l'hôpital, il fait encore un tampon de démission de l'hôpital. Voilà, ça, on peut dire que c'est bien sûr une chose de Covid. Je ne crois pas qu'on continuera à faire des choses pareilles, mais beaucoup des changements de gestion managériale, il faudra réfléchir à la fin si ça peut nous avoir donné des bonnes idées aussi pour le prochain futur.
Okay, thank you, Professor Aparo. We have to share our experiences. It's very important, as you said. So we have a lot of work to do. We know the situation will never be the same as before COVID-19. I have a question to the people here in the auditory. Are there questions from you to Professor Aparo? Do you have questions? Yes, maybe we can ask. You can ask questions later. I propose now to give you some information about the situation in Luxembourg, because I'm not only the Secretary General of the European Hospital Association, Managers Association, but I'm also working in the Hospital Federation in Luxembourg. Only in a few words, because we are a little bit delayed in our program. In Luxembourg, I can say the situation is also under control for the moment. Yesterday, we tested 6,000 people. We have 620,000 inhabitants in Luxembourg, but we have also 200,000 people coming every day from working in Luxembourg coming from abroad. We had after our testing of the 6,000 people, 86 people who were tested positive to COVID-19. We have actually 14 COVID-19 positive people per 100,000 inhabitants. But the number is increasing. But we have for the moment only 30 people who are in hospitals, who need hospital care, and 5 people are in an intensive care unit. If I compare with April 2020, we had 45 people in the intensive care units. Since the beginning of the pandemic, 125 people died from COVID-19. Actually, as I said, everything is under control, but the only thing which is problematic is about testing, because we haven't enough reactive products for the PCR testing. And that's a problem because the products are made in Asia, and it's not easy to have the number we need every day. Now, if I compare the situation today with the situation at the beginning of 2020, we had a little bit more than 100 people who died, and 1,000 people needed hospital care, and about 70 people died in hospitals. We organized advanced care centers to manage the first ambulance support. We developed also teleconsultation with the medical doctors, and we had everyday statements of the situation we sent to the Ministry of Health. We also bought additional CT scanners for the hospitals, because it's very important to have this kind of equipment also in COVID times. And last but not least, we tried every day to have better equipments. This was really hard at the beginning of the year, because we had to manage it with the people in Asia, and so we decided to make our own masks in Luxembourg, and so some hospitals bought equipments to make the masks in Luxembourg, and now we have the possibility to do it. The chirurgical masks and the FFP2 masks. And that's a good thing, and I think we have to reflect in this way also for other equipments. Another point I want to say is about the cross-border cooperation, because we are a small country, and you know, the region Grand Est in France was very hardly impacted at the beginning of the year, and so we decided in Luxembourg to have some 12 patients from region Grand Est transferred to Luxembourg. And that was a good decision, and I think it's very important to work in this way in Europe because, of course, there are differences in the different regions, and if one region is more lucky than another, so we have to help each other, and that's a very important message.
Thank you, Marc. It's really interesting, your presentation, because you share with us your experience, and based on the presentation of Professor from Italy, it's I think, a beginning of the panorama that you can have from Europe. The thing what I want to, maybe if you have a question or not, to continue in this way of presentation. The last point was interesting, and how these countries share their supply system or this hospital system, and how they can collaborate together. It is a very important point from my point of view. What do you think about the logistics? As you said, some patient from France were sent to Luxembourg, and they managed inside the hospital. Something interesting, but is there any information system that is set up to make possible this collaboration or not?
I think we have to collaborate on different levels. Of course, helping each other to bring patients to the right places where we have enough place, but also reflecting on what we can do better, and maybe we can also purchasing, for example, is very important, and we could reflect how we could do it in a better way together in Europe.
Right.
So this could be also a very interesting idea to discuss.
It's really amazing situation in Italy, they have left some months ago, on the situation right now. I maybe invite Mr. Blua to share with us the experience of France. Yeah, and
yes,
to give some
with pleasure.
Yeah. And then maybe we'll ask the audience if you have some question at the end of the presentation of Philippe. Thank you, Marc.
Well, I will not speak a lot about the general situation because it's very similar from Italy and Luxembourg. For example, for the moment, we have much more positive people, and not a lot of people, not a lot of inpatient. For example, in our part of France, at the top of the crisis, around April, we had around 300, 350 inpatient, and now in our department we have only 20, less than 20 inpatient today for in reanimation and in intensive care, and 6 in other beds. So, but you know, of course, at the beginning of the crisis, we have not enough tests to look for our inpatient, and now we are able to make around 1 million of tests each week. So it's always the same thing. When you're sick, you find. So that certainly is the reason, because we find more and more people. We have COVID, but are not symptomatic, and there is not so much people in beds. I will speak more about the hospital point of view, and for hospital, the crisis was first a big logistic problem, and second point, a big managerial and communication problem. About logistics, there is 3 main points. First, the patient. In some part of France, you know, in France, the main number of people who we have COVID, and the main place of people who need to go to hospital was Great Est of France, the east part of France, because there was religious meeting in Alsace near the German border, and every people are together, and after they come back in their turn and give the COVID to people around them. And also in Paris and its suburb, because it's a bigger bigger town in France, near 20% of the population live here, so there is a lot of, it was very easy to have contact between peoples. And the problem is that we have not enough beds for intensive care, so we have to manage, it was a logistic problem, to manage the transfer from of the patient from Paris or from east of France to first to the country, because the first help come from Luxembourg, Germany, and Swiss, and I thank this country for that, and the colleague of this country, and also to the rest of France, because in, for example, in Aquitaine, in Bordeaux, in also in the southeast, there was not a lot of people who are sick, so there was a lot of place for in emergency care. There is also a problem in hospital to create special way for patients who have COVID, and to separate everywhere in the hospital people who have COVID and people who have no COVID in emergency, to go also for to scanner. In my hospital, we have a scanner for patients who have suspected to have COVID, and one scanner for the other patient. And also we have to create some beds, a lot of beds, 350 in here for patients, and so we have to close a lot of beds, and also we have to make transfer from patient in other hospital. For example, in this town, in Troyes, the hospital, the public hospital, take all the patients, keep all the patients with COVID, and send patients without COVID, for example, to the private hospital when it was a surgical problem. Second point of logistic, it was the supplies. It was all around the supplies. At the beginning of the crisis, we have a lot of problem, like in other countries, to find individual protection, of course, masks, but also things like overcoat and so on, to have enough tests, and to have drugs with cura that are very useful for, of course, for emergency care. So during around 1 month, it was very, very difficult, and if hospital have some reserve, it was good, but if you have not, it was very difficult to work. But the government takes the hand on, takes the control of this kind of supply. And yes, after 1 month, it was a war economy. But after 1 month, there was not a lot of problem to work. Also, it's quite unusual, but there was a problem at the beginning to have enough access to internet, because we use more and more video conference, we use more and more telemedicine, and so we need more access. And at the beginning, there was a little logistic problem about that. The second point was the managerial and communication problem. It was certainly the most important and the harder point about management, because we have to change a lot of workers. And for example, we close a lot of services, medical services in hospital, and we send the nurse of these services to new beds of intensive care. And in my hospital, to upgrade the number of intensive care beds, we use 240 nurses of services. So we have to to organize that, to teach to these nurses how to work in emergency care. It could be a little different than if they was in medical care or surgical care. And also, we have to change also the work of other people. For example, the secretary, people who work in secretary go at around the hospital to control the access, because we close the hospital to a lot of people during the crisis. Also, a big problem of management was the psychological problem, because at the end of the crisis, nobody knows the disease. So when you don't know something, you are very anxious. Also in the media, in TV, in social media, in newspaper and so on, there was a lot of very anxious information, and so it was very difficult for people. And also because the situation, the medical situation change every day, the rules change near every day. I remember in one hospital of my group, the mantra people said each day, truth of today is not the truth of tomorrow. And it was very, very difficult in one organization to change the rule each day. In our hospital, there is 4,400 people who are working. Explain to 4,000 people that they have to change, they do every day, it's very, very, very difficult. And also there was a lot of fear also in medical staff, of course. So it was very important about management to be able to reassure and to explain, and to be very united in the decision. And a big job during all the crises, more of course at the beginning, it was to working about that. And for example, in our hospital, we make several working groups from the different hospital to share the decision, to share the element and decision. And there was a decisional group, working group with a representative of all hospital. And the key thing is that to have a consensus that everybody agree with the decision, and so be able to accept that decision can change, rule can change very, very often. And also, that last problem, perhaps more now, is to manage the post-traumatic symptom in our staff, because like in a war, you know, there was some people that, yes, no problem in front of the disease, no problem in front of all this change, but for some people, there is really a post-traumatic syndrome. And the holidays was not enough to close the door of the past. And now I think it's a big problem of management for the second wave.
Thank you very much, Philippe. It's really interesting. From my feedback, we can be together if you want to, there is, even the countries is different. Each country is its own behavior. Finally, you manage the same situation in Italy as in Luxembourg, as in France. Do you think that there is a more specific, because I still asking myself what happened from to have a huge wave in the beginning in Italy and slow here, I think the same in Luxembourg. Is there any feedback about that? Est-ce qu'on a un peu un retour pourquoi ça s'est aussi été imposant en Italie au départ, un peu moins ici? Est-ce qu'on a analysé sur ça et que l'anticipation est intéressante?
I think for the first wave, it was a question of chance.
Okay.
Are you lucky or are you not lucky? Because, you know, in like in every country, the main tool to win against the first wave was the lockdown.
Yeah.
And for example, in Great Est, the problem was this this religious meeting,
Okay.
and if the lockdown began just before
Oh, yeah.
this meeting, there was no meeting, and certainly the waste will be only around Paris and not a lot in our part of France. So I think there is because all the country, I seems in my mind, do near the same thing, but some of them was more, yes, there was more deaths, and I think more there is the density, more there is people, more there is big city, more you have chance to have a big problem.
Density,
and at the beginning,
yeah.
Chance or not chance.
Same idea, Marc? The same analysis about that?
With Philippe, yes.
Yeah, perfect. Thank you so much. I think if you can stick to our program.
I propose we have now a break for 10 minutes,
10 minutes, yeah.
because we are delayed. So we will start again at 3:45.
Perfect. Yeah.
Okay.
Yeah. And the people with us in the network still with us, you can have a coffee or water, whatever you want to drink. We will come in a couple of minutes. Thank you.
Mr. Hastert.
Se ressourcer autrement que par le partage de connaissances.
Je vais peut-être envoyer un mail aux 3 prochains
oui,
pour leur dire qu'on est en retard.
Ouais, s'il te plaît.
Mr. Hastert.
Ouais, d'accord. Comme tu veux. Il y a des questions. Hein.
Il y a des questions encore?
McMahon.
Oui, mais on va pas faire ça après plutôt.
Correct pression, we are regional difference, perhaps climatic or genetic reason. Ah bah tu vois, il y a une autre explication à Aparo.
Les gens discutent entre eux.
Ah oui, discutent.
Ouais.
Il y a un vrai débat. Bon, on a laissé le Zoom et Aparo dit, mais c'est ça que Aparo dit, c'est peut-être attention, ça peut être climatique et ça peut être aussi pour des raisons génétiques.
Oui. Mais bon, là, maintenant, on est obligé quand même de continuer.
Ah non, ça ne change rien, c'est des trucs qu'on va garder. Tout est stocké, on est d'accord.
Bah, c'est parfait.
Mais au contraire, ça, c'est l'originalité de ce mode.
C'est exceptionnel. On n'a pas de retour écran. Je te laisse la main pour manager les autres pays.
Vous faites ça très bien tous les deux.
Non, parce que c'est même la crédibilité, tu es plus crédible que moi.
Oui, non.
Non, mais
Tu me sais même pourquoi.
Non, mais je veux dire, si tu pour reprendre en français les trucs qu'ils sont en train de dire,
Ah oui,
je suis plus à l'aise que moi j'ai vu. Contenu, je pense que si tu parles de management plutôt, c'est moins fiable que toi, largement.
C'est bien aussi quand c'est quelqu'un d'extérieur qui pose des
Non,
questions.
mais j'essaie de faire le neutre, le condile, mais de réagir si tu veux. Can we start? We have the person. Merci à tous d'être encore là. Donc, on va reprendre notre discussion et on va prendre la dernière partie avec du plaisir de travail fait, mais aussi encore d'avoir 2 sessions intéressantes et 2 panels intéressants à discuter. And then since in the beginning we decided and we said that we have 45 minutes for each panel, I think if you agree with me, for each time the participant will have 5 minutes to have like a global 5-10 minutes of global presentation, and after that we have a couple of questions and make like an exchange with audience and the network. Okay, we are waiting for the 3 people. Who is with us right now?
Hi.
Perfect.
I am with you.
Perfect. Yeah. If you are alone, you can remove your mask.
Okay.
Thank you. Parfait. Merci beaucoup. As you guess, we balance between French and English. I think we'll have even German. We try to translate as we can. Yeah. Marc is a German speaker. It will be easier for him. It's okay.
The presentations will be in English, no?
Yeah.
Okay. Sinon, j'essaierai mon français.
Perfect.
1 minute. Hein?
Yeah, no problem.
Pardon. Okay.
Oh, perfect.
Short one.
It's amazing you have your.
Et l'autre monsieur.
It's yours. It's impressive to have the people like this on the stage, you know. I will let Marc introduce the speakers and.
Okay, so I propose we go on with our program. We have now our second panel, and we have 3 speakers from Portugal, from Greece, and from Hungary. From Portugal, we have on the screen Alexandre Lourenço. He's the president of the Portuguese Association of Hospital Managers, and he works as a hospital administrator at Coimbra University and Hospital Center, the major hospital in Portugal. Alexandre Lourenço is also involved in the work of the World Health Organization of the WHO, and also in the work of the European Association of Hospital Managers, and he is a member of our executive committee. So, Alexandre Lourenço, the floor is yours. And first, I propose you give us some explanations about the situation in Portugal nowadays, today, and comparing with the situation at the beginning of 2020. Thank you.
So thank you so much, Mark. I have a presentation, but I can start with what you are requesting. Actually, I believe that we are starting a second wave. At least there is an increase. I'm hearing something in the back. And we are probably entering in the second wave. The incidence is increasing. But I will try to show you what we have done since the beginning of the pandemic, and with this kind of narrative where we could follow what we have done in Portugal and what we expect to happen soon. I believe that you are seeing my screen now, and thank you so much for having me on this forum with other colleagues. So we started with a situation of uncertainty and the need to adapt the healthcare system to this pandemic. I will be quite fast in this part, but actually, in Portugal, after we saw what happened mostly what happened in northern Italy, actually in Portugal we confined and introduced confinement measures, these physical distance measures, before the first death in Portugal. So I must say that in Portugal, I believe that we had a mild problems with the infection, and probably most of the problems that we are having are not related with COVID at this point, and I'll try to show you some studies that we have done. But actually, we started these confinement measures earlier than other countries, as I told you, before the first COVID death in Portugal. So actually, we had this mild pandemic. So the kind of scenarios that we have seen in Spain or in Italy were not seen at all in Portugal. But what we understood is that our capacity of hospital managers is quite dependent in the community response and on the individual behavior of everyone. So we understood clearly that the most relevant to allow us to provide adequate care was to implement these measures at the individual and community levels. We started mostly also most of the countries to start this communication with the population to clarify the first point of contact. So we started in Portugal. Everyone knew that they needed to contact our helpline. Actually, in the beginning was quite a mess. Our health system helpline was quite overwhelmed. And after we increased our capacity and things started to work perfectly. So before someone come to our emergency room with suspicion of COVID, they should go to call this helpline, and it worked quite well. Also, we define what could be the entry points in the emergency care. We defined two major hospitals in Porto and in Lisbon to receive the first cases, and immediately we create these dual pathways for respiratory conditions and non-respiratory conditions at the emergency departments, and also that worked quite well. From those first 2 designated hospitals, we evolved to a second level group of hospitals, and then all the network was engaged. Most of our work was related, and our most concern was related with intensive care. And actually, that was a problem, I think, in every country, at least in Western Europe. And actually, most of our elective activity was stopped, postponed, and actually, in some hospitals, we even used our operatory rooms to hospitalize COVID patients that needed to have mechanical ventilation. So we use all the resources that we have. Even in my hospital, we identified nurses that had experience in intensive care, because even our current intensive care units work below the need. So we identified nurses and intensivists that were working in other areas of the hospital and not specifically at that point in intensive care units. Also, most of our strategy was organized for expanding services to home. Actually, we hospitalized less than 10% of overall number of COVID cases. At this point, I believe that we are in 5-6% of the cases that are hospitalized. So we developed also home services. There is, since almost the beginning, an app where we can, that is called COVID Trace, that family doctors follow patients remotely. And this app was also very, very relevant and continues to be. Anyway, we continue to maintain this continuity of essential services, but we free up our capacity, as I told you, by hailing down the surgeries and also medical appointments in our hospitals. And then we train and repurpose and mobilize healthcare force, of course, according to priorities. And at the beginning, I must say also that we had lots of problems in access to personal protection equipment. In beginning of March, there was lots of concerns on it, and he started to mobilize also community resources, where several companies also supported hospitals in developing and providing even gel for the clinic gels and all the PPEs that you can imagine to support hospitals. So the community was quite relevant at this point, where most of the goods that would come from China were held also by the pandemic. What we started also, even in my hospital, in other hospitals, is to anticipate and address these mental health issues. Mostly in our professionals, we created this psychological helpline also for professionals and also for the community. But most of our concern, at least in my hospital, was directed to healthcare work, our healthcare workforce that was on the front line. So we created these phone lines to support, psychological phone lines to support healthcare workforce. I must say that in the beginning, most of our nurses and doctors, I don't know if it was like that in France, but they were completely mobilized, and there were recommendations not to be in contact with their families. So we created also this kind of structures where they could stay, and of course, being far from the family and all that created this kind of additional stress. So most of our response, I must say, that is about flexibility and preparedness. We even created new units in our hospitals, mostly in the emergency rooms. We built even this new structures for responding to this first level of crisis. And even and you can see in your right, for example, a CT scan that we implemented in the hospitals, just dedicated to COVID. And even this was a project that I was involved with the European Commission, where we could with artificial intelligence, diagnose also COVID by the CT scan. And as you remember, the tests were quite slow at that time, and we needed to wait at least for 24 hours to get the result. So this was quite important also at that time. So our role at the hospital at the beginning, we started always to this multi-level approach. Asymptomatic, they stay home in quarantine. Mild cases, they go home. As I told you, they are more than 90% of the cases. Moderate cases, severe cases that need oxygen therapy, and critical cases that need mechanical ventilation. This was mostly our approach, our clinical approach to the cases, and we developed clinical pathways for each one of these clinical stages of the disease. The Portuguese Association of Hospital Managers, we also developed, and it's available, and a tool that is being used worldwide. This is the Adapt Search Planning tool. That is a tool that we developed for WHO and was adopted worldwide, and you can download it, but from the World Health Organization website, that help to predict the evolution of the pandemic and also what are the resources that you need, like hospital beds or even nurses or physicians. At this point, the tool also allows you to predict second waves and what would be the resources for second waves. And also, actually, at this point, the tool is also predicting the resources for home care and even contact tracing. So I engage you if you want to use this tool. It's not so easy, but you have a manual to use it. But it was developed by us and endorsed and used worldwide by several countries that are using it now to predict second waves and the need of resources for second waves at this point. Also at the Portuguese Association, we realized that was quite hard to get training and information and good quality information across all the providers. So we developed several webinars at the beginning, and still training webinars that we engage also with the health internationally with the World Health Organization, but also with Brazil, with African countries, and of course locally, and with our neighbors from Spain. So several webinars. I must say that we are millions of views at this point, and all these webinars are available in our YouTube channel from our Portuguese Association of Hospital Managers. We also released these two special editions of our journal. One in the left, you say thank you in Portuguese, obrigado. That was dedicated to healthcare professionals, and the second one also one mostly to narrate what happened previously, and the second edition was mostly thinking on the future and what we need to do on for the future and how to prepare the system for second waves and afterwards. We also started and accelerated a program on training in this idea of going digital. We have an academy for healthcare managers in Portugal, and we moved this academy, this training program, to digital. And you see in the right one of the programs that we developed, that is business as unusual. So mostly to train managers and healthcare managers, hospital directors, and system change and dealing with crisis and new problems, new talents. So actually now we have more than 10 courses, online courses that healthcare managers, and actually they are open to all healthcare professionals. They are open and you can have access to them on training programs remotely. So we change our training programs to this remote. Also, we developed awards. Actually, we have more than 100 applications for this Healthcare Excellence Award Special Edition for COVID. We also give face masks to all our members, and they were distributed in all hospitals. One of the issues that we are very concerned in Portugal is the issue about bed blockers. Annually, we have a survey of bed blockers. This is the overall study that we have done, but we did a special edition also in bed blockers for COVID patients. and we realized that 20% of the COVID patients that we have hospitalized, they didn't need actually hospital services, so they could be treated elsewhere in extra hospitallary institutions. So this is one of the issues that actually we are dealing now with the second wave, is to try to have these backup hospitals or backup structures to allow us to increase our hospital capacity by reducing the number of bed blockers with COVID. So the issues that we realized from all the COVID situation is most related with this the need to replace frontline healthcare workers. We believe that they are tired. I don't know how they are going to answer for the second wave. Also, we are concerned with mental health disorders due to confinement and also for the human resources burnout. I will show you, at least from our knowledge, the idea that we are going to have an increased need for hospital and healthcare services due to cancellation of our elective activity. And also the increase of unemployment and poverty will also, of course, have an effect in the needs of our population. And actually, hospitals at this point are running with higher operational costs due to the use of PPEs, regular testing. All patients are getting testing, chronic patients, surgical patients, they are getting tested. So this is increasing our costs. We increase all the clinic routines also in hospitals. And of course, we have a reduction in our productivity due to the all new activities that we need to implement in our hospitals. Concerning with this, the Portuguese Association of Hospital Managers and the Medical Association, we publicized, we did a study. This is in Portuguese, but mostly what we have tried to analyze is the reduction of access to care due to COVID. And not to COVID patients, but to non-COVID patients. And this is quite one of the issues that we are more concerned with. We have seen a reduction in the activity of primary care. Even in hospitals, we are seeing reduction in the referrals from primary care. And we believe that most of the diagnoses and initiation of treatments, they are being delayed with, of course, some consequences in morbidity and mortality of patients. We see this is also in secondary and tertiary activities. We have saw a reduction in 40% of our medical appointments, 24% of our surgeries. We have seen a reduction also in our emergency rooms. So we are really seeing an impact for non-COVID patients. I must say that also we realize that in our emergency rooms, we have seen a reduction. I don't know if some countries use the Manchester triage in emergency rooms, but what we are seeing really is something damaging in the most complex cases. So mostly in the red and the orange and the yellow cases, that we see a major reduction in the emergency room attendance with consequence to the patients. What we believe is that patients are afraid to come to hospitals, and that's why we developed a campaign. I will, let me, bear with me just a while, just to show you a campaign that we developed. I will try to have my sound with you.
COVID-19 has put protection on the agenda. And if you're protected on the outside, you should be protected on the inside. So, do not mask your health. Pay attention to your symptoms. Keep doing your treatments and necessary tests. Neglecting your health can become a serious issue, and fear is still the most dangerous of diseases. Remember that seeing a doctor is still necessary and safe. Always wear a mask and make your health a daily priority. A recommendation from the Portuguese Medical Association and the Portuguese Association of Hospital Managers, supported by Roche.
I don't know if you had the opportunity to see it, but this is a campaign that we release in the media. I hope that you saw it, because I never know with the technology. We developed this campaign mostly also to in the social media and on TV to engage patients to not be afraid to come to the hospital. So this is a major campaign that we are quite engaged with. We also have done studies in the consequences of a second wave, and if you are not prepared, and also we need to postpone elective activity, and we see major consequences in access to care. So we are quite concerned in the next few months about this. So most of our strategy is to continue to manage this dual system, this dual pathway system, where we can catch up cancel activity by the increase of e-health, and we have a major increase on e-health utilization, but also to maintain this flexibility, COVID, not COVID, to maintain this balance between services. What we believe that actually this is a serial killer. We are afraid, of course, all the respiratory diseases that are going to emerge due to the cold weather, and we are, of course, afraid and concerned what can happen in the next few months, knowing that this uncertainty will continue to put additional pressure in our system. But we hope for the best, and I also hope for everyone that is also on the call and worldwide to manage this situation the best that they can, because it will not be easy at all for any one of us.
Okay.
Thank you.
Thank you, Alexander Lourenço. As we could see, there are a lot of things we can improve, and also on the level of hospital and health management. Maybe there is just enough time for one question. Philippe?
Hello, Alexandre. Perhaps one question. Your country have a very big border with Spain, and in Spain there is a lot of people who have COVID and died of COVID, and not a lot in your country. How do you protect your country about the COVID?
No, what I try to explain is that actually we implemented the physical distance measures before the first death that we had. We have secondary infections. We believe that we didn't have direct infections from China, and so most of our first infections came from northern Italy. So we had the time to implement these confinement measures. At this point, we have lower levels of incidence of COVID when we compare with Spain. Even in Spain, what we see is lots of pressure in Madrid, not in the overall country. But of course, we need to be aware that we are living in a global community, and what we are seeing, and without the possibility or the political possibility to implement the strict confinement measures in the next few months, we need to be, at least at the hospital sector, quite concerned about what is going to happen in the next few months. What I also believe is that hospitals are quite dependent in the behavior of the community and in the behavior of other healthcare services like primary care, advanced posts for diagnosing COVID. We continue to have drive-thrus, I think, for diagnosing COVID. It is planned to have these advanced posts for respiratory diseases. But anyway, I believe that we are going to face something that you never have seen, and probably the impact in Portugal in the next few months will be much higher than what we have seen in March and in April, that it was quite mild when we compared what happened in Portugal with Spain or with Italy.
Thank you, Alexander Lourenço. Now it's time to switch to Greece. Our second speaker is Georgia Oikonomopoulou from Greece. She is a senior management staff at Ellipse Athens General Hospital, and Georgia is also a member of the board of the European Association of Hospital Managers and of a board member of the board member of the Hellenic Health Services Management Association. Georgia, the floor is yours.
Good afternoon from Athens. I have to say that my friend and colleague, Alexandre, gave us an effective hospital manager feedback and hitting all the right points. Undoubtedly, as the new decade began, while I'm trying to share my screen, give me 1 minute. Well, okay. As the new decade began, as I was saying, everything rapidly unfolded into a scenario that the world will be remembered for years to come. We're experiencing an unimaginable global viral pandemic of zoonotic origin that our collective imaginations over the coming years will be overshadowed by a virus that took fewer than 100 of days to shut the world down. As COVID-19 swept across Europe, Greece started implementing nationwide measures to contain the virus, including cancellation of major public gatherings and lockdown measures. And that measures went along with healthcare system in ICU capacity, tracing, closed to home unit services, and many more. In summer, we reopened the airports to international travelers, of course, with restriction of flights from countries considered high risk were and still remain in place. It was in the hopes of salvaging this year's tourism season and easing an anticipated recession caused by coronavirus lockdowns. I'll first show you some data about Greece and the country's highest rise since May. This is from the last 15 days. But data is still encouraging, with countries' death per 100,000 of population to be at the lowest in Europe. And that even if we are concerned with the recent spike in coronavirus cases and have set up mobile units to conduct more rapid tests. Athens, sorry to tell you that, remain the epicenter of the new infections. The way we have experienced and viewed healthcare has changed over the last 9 months. And organizations are looking for ways to address new unexpected challenges at rapid speed. Our additional challenge is to cope with COVID-19 cases of refugees and migrants. According to virus estimates, about 150,000 displaced persons are located in Greece. In the existing camps, measures against the spread of the coronavirus are lacking as people live in overcrowded spaces. By late of September, half of the COVID patients in 2 major hospitals of Athens were immigrants. There are 3 main topics of challenges in healthcare delivery and reduced spread, and those are communication, continuity of care, and confidence. But these very harsh times have taught us that the best outcomes always comes with collaboration and consistent efforts. When government authorities and hospital organizations join efforts, the results are better as together we can open a safer umbrella towards marginalized population. In this battle against time, no one is to be left behind, and Greece is proving so. I very well know that it's unorthodox to conclude before develop the points, but this is the core message. If we take care of our staff, then the staff will take care all in need. This is the message that my colleagues in Hellenic Health Services Management Association took from this pandemic. Next lesson is encouragement. It is essential for health workers to see leaders present. Staff must know you and their organization truly care for their well-being, guide, help when is needed. Keep contact and telephone in staff that is in quarantine is a key factor to ensure people, healthcare forces, that you care. And of course, continuous update in preparation and hospital emergency planning. And we all know that the very resource-limited circumstances is a huge, huge challenge. Thousands of healthcare workers lost their lives as a result of hospital-acquired infection. Last estimation was about over of 7,000 workers that have died. It's our responsibility for taking care and protect the staff. For example, assuring PPE supplies needed to be managed, of course, carefully and enough to make employees feel secure, or provide regular breaks for rest. I know this is very difficult, but it was one of our association promotion. As long as with psychological employee support by employing mental health specialists on call. Last but not least, training and training. Find the right and important information that staff needs, communicate it to all on a regular basis. And of course, listen, sharing thoughts, sharing concerns about the situation is crucial to ensure that staff trust you. A good and direct and clear communication may reduce a lot of fears. At Hellenic Health Services Management Association, as the pandemic continues, everything we do looking at connecting these dots between experience management and an operating framework to help hospital managers in minimizing risk to patients and healthcare personnel. Along with colleagues in European Association of Hospital Managers, are waiting for COVID-19 to become that game changer, a game changer in awareness for hospital workers' safety. Thank you for listening.
Thank you, Georgia. Thank you. It's sometimes difficult to manage time, and this afternoon we are a little bit
very
late.
short here, Marc.
It's not your fault, but we have to manage it here. So I propose there's certainly questions for you. You have the possibility to ask the questions on your screen. Or by using the email address of the site of the conference.
The SHeIC.utt.com. Yeah, this is this one. Yeah, this is the good. You have it in the www.SHeIC2020.com. You can go and you can send your email if you need. No? Okay.
Okay, so we propose to go on with the other speakers. Thank you very much, Gogo. And you will receive the questions by email or directly on your screen. So the next speaker is from Hungary. It's Dr. Lajos Ari. Lajos Ari is a medical doctor, and very important, he's also the head of the local scientific program committee for the 29th EHM Congress, the Congress of the Association of Hospital Managers in Europe, which will take place next year in September, October in Budapest. Dr. Ari shows us slides in German, but I think it will be possible to translate the slides later, so we can put them on the site. So, and I think you will speak German. Do you hear me?
Yes, I hear you.
Yeah, okay. Do you speak in German or in English?
My English is too good, but I try to speak English.
Yes, if you can, please try to speak English. Otherwise, I will try to translate. Okay.
We make so what is too simple.
Sorry, we have some problems with the sound.
Okay. Now, is it now better? Hello, is it now better?
Yes.
Yes, it's better. Can I speak? We understand nothing. We don't hear anything.
Yes, I can hear you. Ari, Gerry,
yes?
In Ireland, yes, I can hear you very clear.
You hear me very clear.
Yes.
Okay. Then I begin English, and if I have difficulties, I continue in German.
Okay, the floor is yours.
I am the last speaker, and I thought my idea was to make a summary. The idea was for me, I am retired, and the two speakers spoke very exactly what must we do if we have a pandemic problem. Everybody in each county is the way quite the same. It depends from the only from the around of the hospitals, and this is why my idea make a summary, a global summary. He is the hero, and we can imagine what can make the policy with a doctor if he talk but don't feel is good for the politics. I made a balance. Each money has two sides, a positive side and a negative side. The negative side only shortly, the many tragedies all over the world, but it's very important, the vulnerability of the world, global, regional, or in the certain counties, in the ecology, in the economy, in the healthcare too. You can imagine what I mean, the human resources, the technical side, the orders, the waiting list. We haven't therapy, but it has positive sides too. Our colleagues made a very strong work. They were extraordinary. And the vulnerability, it is a mirror. We can see in the mirror what is wrong in our world. And it is time to reboot our world. The innovations, the cooperation between the pharma industry, in the informatics, in the healthcare, all over the world. I remember many people are going from one county to the other at the beginning of this pandemic. They got help. The fake news is a very big problem. The panic on the population, the quarantine, the closing of the borders, if Hungary closed the first time the border between Austria and Hungary, it was a big problem in Austria in the healthcare. Doctors and nurses can't go over the border. Any days were there a big problem. The problems in the economy, the mental status of the peoples, the testing, how, with what kind of tests, the price of the taxes, what is the positive side, the international cooperation, the work of the WHO. The big population was there about this. Had made discipline. We had the masks and the social distances. Many private initiatives, the cooperations, the new attitude of the pharma industry. They make the development of the research together. The next. Now, two pictures about the quarantine. You can see two cards. One is from made in Hungary, and the other is from the European Union. I know this is first time the quarantine and to close the border. It's to protect the counties against the sickness, but it is politics and economical toy too. And this is very important, the facet. What can we learn about that? Our life must be changed. The first sentence, what you see with the red scripts, is the Hungarian linguistic game. You can see that the traduction, Freiheit ist nicht gleich Ungebundenheit. Demokratie ist nicht dasselbe, dass wir Dummheiten sprechen können ohne Kontrolle. Und bitte mag das so zuerst übersetzen. Es muss klipp und klar festgelegt sein, wie, wann, kann, muss die Gesellschaft, das Gemeinwohl, das Recht des Individuums einschränken. The responsibility for the peoples and for the social media is very important. First time, the fake news. The second time, don't give place for the virus skeptical. Don't give place for the people who don't want to get and that speak against the vaccinations. We must think about the globalization. The healthcare and the social work must be much stronger. We have problems in the structure, with the human resources, with the infrastructure and the financing all over the world. Some countries have a better structure, others has a not too good structure, but the financing is everywhere problems. The education and the post-education must be most nearly to the praxis and must be more flexible. We must educate the people who are sitting before the TV and listen to the radios, they read the newspapers. The patient's education is very important. We must think about the politics in the economy. We must learn how we must work, and we must reboot the industry. Not everything must go to the Eastern. We must work. We must make many things at home too. The world is not. Die Welt ist nicht unsere Welt. Das haben wir nur von unseren Nachbarn geliehen bekommen. Also wir müssen auf die Welt aufpassen. Protect the environment. I want to make a little bit travel in the time. Und das würde ich jetzt, that why I speak in German. Die Gesetze sind nur dann brauchbar, wenn ihre Misshandlung geahndet wird. Ein Beispiel der Quarantäne. Die Kaiserin, Königin hat 1770 der Generale Normativum Rei Sanitatis geschrieben. Das war ein Gesetzbuch für das ganze Reich. Da waren viele Kapitel über die Quarantäne. Die Quarantäne war damals gegen Pest 48 Tage. Aber wer das missachtet hat, der wurde sofort erhängt. Die Todesstrafe. 1867 hat das Ungarische Reich dieses 14. Gesetz entlassen. Das war der erste große Kommunalgesetz in Ungarn. Ich habe das Ganze durchgelesen. Es ist so gut geschrieben, dass wenn wir es jetzt ein bisschen erneuern würden, in der jetzigen Sprachenwendungen, würde es 100% passen. Die ersten 8 Paragraphen waren die Strafen und 10 Paragraphen waren über die Seuchen und Infektionen. Was wichtig ist, Quarantäne war damals hauptsächlich in den Krankenhäusern.
You say the first.
Dann bin ich fertig. Das erste Bild zeigt ein Quarantänezentrum 1937. Das musste der Familienchef, also der Vater, auf der Tür kleben. Und da kann man sehen, wenn die Quarantäne nicht hält, der musste 600 Pengü bezahlen. Das waren 3 bis 4 Monate Gehalt eines Angestellten. Also die Strafe war klipp und klar. Das ist, was wir jetzt dieses Jahr dann aushängen müssen. Da siehst du die Paragraphen, aber wir wissen nicht, was die Strafe ist und wo wir diese Strafen finden können. Und merci danke für Ihre Aufmerksamkeit. Merci beaucoup. Thank you for your attention.
Thank you very much, Lajos Ari. So I wanted to say about the last slides, and you insisted about the penalties.
Yes.
And in the past time, there was more text about penalties than about care. And now we hope it will change. And I'm sure we have a lot of questions also to you, but as I said before, we will send you the questions by mail, or you will receive them on the screen. And don't forget, we have next year, let's hope, our Congress, EHM Congress in Budapest. So we can meet you in Budapest, and I'm sure we will have also a lot of things to discuss about COVID during the Congress in Budapest. And let's hope the situation will permit us to come to Budapest in September, October next year.
We hope
Thank you. We don't hear you.
Zsuzsa Jakab, the Vice Director General of WHO, is one of our guests. And we plan with the mental committee program about the post-trauma effects of this pandemic.
Okay, so I invite everybody to look at the Congress next year in Budapest. Yes. Okay, thank you very much, Lajos Ari. So now we come to our last panel discussion of the afternoon.
I don't know if I have the possibility to tell something.
Alexander, do you want to say something?
No, yes, just to let you know if any country or any of the participants feel that the video that I show you about the need to address the population and the need for them to have access to care. If they want to use it, please let me know. I don't know if you have seen it, but I can show you again even the video. But you can contact contact Marc to have access to that video if you feel that this can be useful for countries.
Okay, thank you. So now we come to our last panel discussion with speakers from Ireland and Northern Ireland, UK, and Iceland. The first speaker is Gerry O'Dwyer. Gerry O'Dwyer is the Chief Executive Officer of the Southwest Hospital Group in Ireland, a big hospital group. And he is also the past president of EHM. Gerry, the floor is yours.
Okay, thank you, Chair. First of all, I would like to commend and compliment the organisers of the event. It's been very beneficial, educational, and indeed inspiring. And thank you for the time and trouble to the organisers who made the effort, despite the challenge that we have in these terrible COVID times. So just to say that. In Ireland, I suppose a lot of what has been said by the previous speakers, I'm not going to dwell on, just to acknowledge that there's an awful lot of similarity between what some of the previous speakers would have said and what I'm about to say. So in simple terms, in our country, we've had about 36,000 cases, pushing 37,000 cases. We've had 1,800 people, unfortunately, who died, and that's the national position. We've had particular challenges early on with the supply of PPE, which some of the speakers, and particularly Marc, mentioned from Luxembourg in his presentation, and we have had to undertake similar arrangements to manufacture some PPE here, which I think is important. We were challenged with intensive care beds right across the hospital system. And in our healthcare system in Ireland, we have a system of public hospitals, which I'm responsible for 9 across the southwest. And but there are also some private hospitals, and all of the private hospitals were utilised by the state for the duration of about 4 months. For about 4 months, we had the extra capacity of using private hospitals to support the whole public health system. We also deferred an awful lot of activity, and now we're in recovery mode, and that's proved a challenge because although we did flatten the curve, and I'll speak about that in a minute, there's been some adjustments, and unfortunately the curve is now going the wrong way. We did flatten it, and like other colleagues, not as good as Greece though, we were maintaining good progress, but over the last number of weeks that has changed. We now have a system of part of living with COVID. We have 5 levels in the system. Level 1, and just to give you an example so that you understand, I won't go through all of the levels, but level 5 is lockdown. It's more or less lockdown, which we had for a period of time early on. But level 1, and if we mention, say, for example, weddings, which are very important in Ireland, you would have between 100 and 300 people would attend family weddings. In level 1, in a wedding, it's 100 people, a max of 100 people. In level 2, it's a max of 50. In level 3, if we were in level 3, it's a max of 25. In level 4, it's a max of 6, and in level 5, which is effectively lockdown, it's a max of 6. And that'll give you the 5 levels. Then if we go to sporting events, which again is, you know, is common to us all right across Europe. Europeans are fantastic sports enthusiasts. So what we have at the moment in level 1, we have anyone who, an indoor event, it's 100 in level 1, an outdoor event, 200, and in a stadium, it's limited to 500. Now, we're in level 2 in Cork. I cover the south of Ireland, and we're in level 2. So that means that we have 200 people can go into a stadium, 100 people in an outdoor event, and in an indoor event, 50, correct? Now, Dublin, the city, our capital city, is in level 3 at the moment, which means, you know, effectively most outdoor events and large events, you know, they're not encouraged to take place at all, correct? And, you know, and for example, if you're getting married in Dublin today, in a marriage ceremony, it's a max of 25 people. So just that you be aware of it, they are the 5 levels. This is part of our living with COVID. There's significant emphasis on wearing masks, particularly from level 2 up, but all the time. And we were encouraging a lot of people to work from home. And we're also encouraging people to use telecommunications, particularly video links, telelinks, etc. And they have to make arrangements from a healthcare point of view with their family doctor or with their clinic, or contact the hospital before they attend. Because in the hospitals now, we have a COVID stream of people who are potentially COVID positive or are COVID positive. And then we have a stream of people who are non-COVID. During the earlier surge, we effectively only dealt with emergency cases. All non-elective cases were cancelled, and outpatients departments were cancelled, and dealing with chronic illnesses, which our hospitals in conjunction with community services had to do, were practically non-existent. So we've been in recovery mode since about the end of July into August, and we're trying to catch up, but it is a problem. Some of our screening programs have not been re-established yet, but we hope to have those working in the next number of weeks. A lot of all elective surgery, non-emergency surgery was cancelled, so there have been problems since. There's been particularly big challenges with elderly people who should perhaps have been in hospital or with their doctor in maybe May, June and July. So they're coming into hospital now, and some of them are quite sick, and their length of stay in hospital is increased, and the whole care pathway has changed for them. So that's particularly difficult. So we're dealing with that. We've had to reduce our bed numbers to ensure we had proper spatial distance between the beds in hospitals and the beds in community and elderly care facilities for older people who needed institutionalized care or supervised care. So the number of facilities available, the number of spaces in the facilities available have been reduced, in some cases quite substantially. So we have a number of challenges, but our use of technology has worked well. Communication has worked well. I believe our leadership right across the healthcare system has worked really, really well, and we've had outstanding leadership right across both political, medical and managerial, very good leadership right across the system. So we're very well pleased with that. Travel in and out of, we're islanders. In Ireland, we're all islanders here. So we rely on either air travel or sea travel to move from one country to another, as you know, and the air travel has been contained quite a lot. So so the government are encouraging people to stay at home, not to travel. And if you come in from certain countries at the moment, you have to spend 14 days in isolation. And this is supervised isolation in some cases. most of the other issues that I would mention is staff availability. We have a backlog of activities. We used our private hospitals. A lot of stuff worked very well, particularly our data and technology worked well. And we're into the resumption of services between hospitals and communities at the moment. But most of the other, the virtual clinics worked very well. And we did set up a national COVID tracker, which again worked very well in terms of tracking people, etc. Or if there was a contact, you would be now contact tracing was a challenge. We've recruited a number of staff, and we had to get the military in to support us on contact tracing and also on swabbing for various clinics. And we use sporting facilities to assist us to swab the community or swab people who are recommended to come to clinics. And that has worked very well. But we're recruiting quite a number of people now for contact tracing and to continue on the swabbing program, because an awful lot of our own staff, particularly from community services and elsewhere, were redeployed to support tracing and to support communities in different ways. So we're trying to re-establish our services again. So that's where it is. We are doing a paper up for colleagues on it, which we'll share with you in the coming weeks, which all my colleagues are contributing to. So we will share that with all our colleagues over probably in about 2 to 3 weeks from now. So look, that's it, Chair, for the moment. That's a summary. Most of the other issues, both Ugo and Gogo and Ari have covered, so I'm not going to repeat them, okay? But if there's any questions, I'm happy to take them.
Thank you very much, Gerry. So I propose, because we are delayed, that we will ask a question to all the participants at the end after the last speaker. And of course, if people want to ask more questions, as I said, it's possible via the link on your screen or on the email. The next speaker is from Northern Ireland, UK. It's Louise McMahon. Louise McMahon is the Executive Director at the Health and Social Care Board in Northern Ireland. And she's also working very close with EHM. She was also during 4 years the UK representative in the Executive Committee of EHM. Louise, I don't see you on the screen. Ah, okay. So the floor is yours.
Okay, good afternoon, everyone, and thank you for the invitation. And unfortunately, I would love to be in Troyes and to drink a glass of champagne, but maybe in some years when we are free to travel, we can meet again. So as Marc explained, I'm today in Belfast, Northern Ireland, which is part of the United Kingdom. We have had very similar experiences to much of what has been described, but some little differences. Of course, we're part of the United Kingdom, but there are devolved administrations of Scotland, Wales, and Northern Ireland, and we have, therefore, we can make our own arrangements with regard to our actions around COVID. Also, very importantly, we are on the same island as Gerry and his colleagues, and as you know, the virus does not respect borders. And that has been an important collaboration issue for us, and of course, quite political, but has worked well for us. So what has been our experience in Northern Ireland? I think it's important to emphasize, and across the United Kingdom, that we have not been overwhelmed. In these two islands, we had unfortunately for those other countries, we were able to see what was happening in Italy and in Spain. It was on our television screens every night, and that helped, I think, convince the general public, as well as our politicians and other key players, that we needed to take action very quickly. We started our planning very early, back in February, very much led by our Chief Medical Officer. And we therefore, the same as everyone else, we planned on the basis of having very significant additional intensive care capacity, ventilators, skill mix, redeploying staff into support ITU. Of course, as we went through the experience, as people became infected with COVID, our clinicians learned more about treatment, and it became less about ventilation as other methods were used. And very, very quick, dynamic exchange of information between clinicians improved treatment and care. We had other arrangements around the health service. We established vast Nightingale arrangements. You will have seen the big Nightingale Centre in London, which ultimately was not used very much. In Belfast, one of our biggest hospitals became the Nightingale Hospital for Northern Ireland, and that remains protected going into the second wave. Very important for us, particularly in Northern Ireland, is that we have a very well integrated health and social care system. So all of the healthcare system is, it's the NHS, it's all the public system. We also have, in my organisation, we fund and plan and organise all of the hospital and the primary care services. So we were able very quickly to set up COVID centres, a bit like Alexandre described, where general practitioners, family doctors were able to deal with query COVID patients and keep those patients away from emergency departments and from hospital beds where possible. That was extremely valuable. We've also had other opportunities to redeploy. So for example, dentists in the community, they were all closed very early, and some of them we were able to redeploy into the COVID centres or into contact tracing. I'll talk more about that later. Also, very importantly, which was very successful, so hospitals, health services were organised very quickly, and that was quite clear. We know what to do in that kind of situation. But during sort of late March, early April, we became very concerned about the care home and nursing home sector. And we saw what had happened in Spain, for example. But we were able to, with collaboration and cooperation, for example, to redeploy specialist infection control nurses and so on into nursing homes to support that. Of course, a lot of money has gone into all of this, even into, as Gerry said, private hospitals to buy up that capacity, to have contingency available, to support private nursing homes with additional staff. As everyone has said, staffing has been a major problem for us. Of course, I've talked about how we've helped create more workforce capacity for ITU, but as staff were perhaps had symptoms and needed to self-isolate, or maybe someone in their household had to self-isolate, that has consistently caused difficulties in staffing. And of course, that problem existed in care home settings too. So we've had to support that with funding also. So where are we today? So as Gerry has described, we have had very stringent restrictions on movement. Only essential workers come in to leave home. Schools have been closed and so on. So there was a lot of relaxation of that over the summer months, according to the R value, as was so well described earlier. And now we have, the schools have reopened, but particularly university students are back, not only studying, but also perhaps enjoying to party and we're seeing more transmission. Also, the transmission is in households, so individuals are having parties for their granny for a new birth, and that the most stringent constraint now on movement is within your own household. Only 2 households are allowed to meet, even in the garden or in the park or in a restaurant. So that's very strict just at the moment. So we are, as everyone has described, facing into the second wave, and as Gerry described, also the rebuild of all of the other services which were very significantly turned down during the first wave. That is a really serious issue for us. As Gerry has described, we are concerned about people who perhaps needed to come in and were afraid to come in, didn't want to bother us. So we're just a big publicity campaign about that at the moment. But also on an ongoing basis, we have serious challenges with regard to waiting lists, even before COVID. So how we are going to rebuild is taking a lot of our very serious thinking at the moment. But as others have described, one of the big lessons is that we've learned that with clinical leadership, with a lot of interdisciplinary collaboration, change can happen very quickly. We've been very agile, very responsive, and it has been a very safe environment. As others have described, there's been a very significant transformation in the use of online, whether that's patient-doctor consultations and everybody working from home. That there were some constraints on that at the beginning, but we hope that we will be able to continue a lot of that and have those ways of working as a constant way of working. We can see more patients, obviously, not the only way of seeing patients, of course, but we want to keep those lessons that we've learned. So in terms of the one of the things which has characterized our whole approach is that, as I said, the need for interdisciplinary working. So my public health colleagues are in this building. Obviously, we work really closely what's happening with the R rate. How does that then translate? How's that advised to our politicians? Just one point on the politics of it. So we have essentially 4 jurisdictions in the United Kingdom, and we in Northern Ireland share the island with colleagues across the border. We have, medical staff who live on the other side of the border, come into work in hospitals here. So early on, that was really important that the politics could not get in the way of cross-border collaboration, and that has happened very successfully. It's delicate, of course, as is everything. So in conclusion then, our experience has been characterized by collaboration, cooperation. We've had the community and voluntary sector, which we don't often regard as essential to this type of an emergency, but we have had literally, food parcels for people who are shielding, and everyone volunteering. If people were furloughed, paid by the government not to be working, many of those people have volunteered, for example, to deliver medication to people who are not allowed to leave their house and so on. It's a very, very dynamic situation. It's changing day by day, but I'm confident that we will continue to work together and all of the expertise will be deployed to keep our communities safe going into this winter. Thank you.
Thank you very much, Louise McMahon. Yes, we have a lot of challenges to manage, and do not hesitate to ask questions to Louise McMahon online and on your screen or email. So now we come to our last speaker. Last speaker is Dr. Páll Matthíasson. He is the CEO of Landspítali Landspitali is the National University Hospital of Iceland. Páll Matthíasson is also a new member of the EHM Executive Committee representing Iceland since 2020. Please.
Yes, hi. Can you see my slides?
Yes, yes, we can, Páll. Yes, yes, we can.
Okay. That's probably better. Yeah.
Yeah.
Great. Well, it's a big honor to be here with you all guys today, and I've been listening with great concentration on your talks as much as I could, because we are now facing phase 3 of our COVID crisis. So that means that I have to run and deal with that problem from time to time, but I've been able to stay with you through most of today, and it's been really informative. Well, I wanted to tell you a bit about the response of the National Hospital and the health authorities of Iceland. Just first, quickly, Iceland, as you know, it's an island. It's a small population, and these things, of course, affect our response and in some ways make it easier. Although I think, as I will show you, we were able to gain good results, particularly in the first phase, definitely. And that was due to certain factors which have nothing to do with our size or isolation, really. Now, the National Hospital, of which I'm the CEO, is the only tertiary care facility in Iceland. It has 700 beds, around 6,000 staff. And it's clear that we would be a cornerstone of any response to a serious epidemic like COVID. So just to tell you about some of the results that we have, and then I'll go into it in more detail. One of the results was that we used COVID-19 testing really carefully, and we tested a lot of people through partly collaboration with Decode Genetics, which is a sort of a private genetics company in Iceland. We used random testing as well to understand how much of the population was infected. Just the latest results we have are that just under 1% of the population of Iceland is immune to the illness now. If you look at the primary care staff, the likelihood of them being immune, having been infected, is the same as the population generally. But if you look at staff of the hospital, it's only 0.25%, which tells us that actually the knowledge of properly using personal protective equipment, being careful of using it when looking after patients, actually protects you. And not only have we been successful in that, but also our message to our staff that they should be very careful in the community has clearly led to a lower rate of infection amongst staff. Now, our mortality rate in Iceland is thankfully low. Only 10 patients died. The case fatality rate and the infection fatality rate were quite low as well. I would say other issues that are interesting in Iceland are the fact that we had a general public acceptance of the measures that were taken. We were fortunate enough to get away with mild restrictions, meaning that we had to close schools, but only for 6 weeks from mid-March till early May. We did not go into lockdown, but we had a restriction of the size of groups coming together of up to 20. But this was relaxed at the end of May. And at the moment, we are at a maximum group size of 200. Just a timeline of events. We got the first case on the 28th of February. But we'd already in January realized that we would be facing, like the rest of the world's healthcare, a challenge. So we've been preparing. Our laboratories had already devised a test that could be used to diagnose COVID-19 or SARS-CoV-2 virus. And things escalated really quickly in Iceland because a lot of the people who brought in the virus were coming from northern Italy and from Austria, from skiing. And these were kind of middle-aged, middle-class people, a lot of them doctors and nurses actually, who came back and brought the infection with them. So we had serious problems. And actually the first cluster of illness we had was around one of our 2 or 3 intensive care units. But we got through that quite quickly. We were able to organize. We were getting overwhelmed around the 20th of March. And that's when we realized that what was going to happen was similar things that we'd seen in Italy, in other parts of the world where actually infected people were flooding hospital corridors. And we had to think really quickly and try and find a way to manage that. And we came up with a solution that was really helpful. And that solution was actually to put all the diagnosis on, make it the responsibility of primary care. But everyone who'd been infected became the responsibility of our COVID-19 outpatients clinic that was managed by the National Hospital. And that meant that everyone who was on the books was called every day, and they had an app as well where they could register their symptoms, so you could actually get more quickly to people who showed serious symptoms. And through this, we were actually able to manage most patients at home in isolation, because most patients actually did not need to come to hospital. But they were called every day and reassured, and they could always get through with their worries. If people needed to be assessed, they were brought by special ambulance to an outpatients clinic we set up with X-ray equipment, etc., all facilities. And only if that assessment proved that people were really seriously unwell, they were brought into the hospital proper, where we had designated wards for patients and also a designated intensive care unit. Now, this COVID-19 outpatients clinic has also proven to be very helpful in following people after the infection, because we found that about a quarter of our patients have had residual symptoms and problems, and that's not necessarily correlated to how unwell people were to begin with. Now, so just to rephrase, the key elements in our response, I think there were 4 points, and in the response that was successful. Firstly, we had a very open, consistent communication from health authorities. So there were daily TV broadcasts. And I think when on the 2nd of April, a quarter of the population watched it at 2 p.m. The people who were kind of always there, they were called the Holy Trinity. So it was the chief medical officer of Iceland, it was the chief epidemiologist, who's an infectious disease doctor, and the head of the response team of the police force. There was a 4th wheel, which was myself. I was there every day for weeks on end as well, but only when the epidemic was at its worst. Now, that was 1 point, because I think it was very open communication. People were really open about the unknowns, willing to admit that we might have to change course very rapidly because nobody knew very much. But people actually appreciated that honesty. And it made it far easier because nobody knew anything. So we had to change course quite often. And if you've been open about it from the beginning, then it's really easy to backtrack. But if you claim to know everything, then that becomes quite difficult. So that was the first thing. The second thing was extensive testing. So we used collaboration with Decode Genetics, as I said. We used quarantine quite a lot. And I'll come to that a bit on another slide. The third bit was the COVID-19 outpatients clinic, which I mentioned. And the 4th bit, which was quite important, was a centralized stockpile of personal protective equipment. Thankfully, we had stockpiled equipment after some previous pandemics, like the SARS pandemic and the swine flu, etc. And we hadn't thrown it away, even if it was out of date, and it actually was working still. So we had that to begin with, but then the National Hospital was given the responsibility of obtaining a centralized overview of how much PPE there was in the country, with importers, with private institutions, etc. Also ventilators, etc. And then we were given the responsibility of actually finding the delta, what was missing, and being responsible for acquiring what was missing. And that proved to be really important. And I actually had to replace the head of our purchasing office with a a senior manager in the hospital who is also a neonatologist. Because actually the decisions you had to make, we had an airplane standing on an airstrip in Shanghai, and the equipment that we were supposed to get, it had been snapped away by someone else, but there was something else available. And you had 5 minutes to make a decision whether we should buy that or not. And, you know, people used to Excel couldn't handle it. So you had to have someone who is able to take quickly difficult decisions based on limited information, like a clinician. You had to put them in charge, and that worked very well. Now, here's just a bit about the testing, tracking, and quarantine. So now, a third of the Icelandic population has been tested for COVID. Thankfully, 57% of those who were diagnosed with COVID after testing were already in quarantine, which is important and shows the importance of tracing infections immediately. Because, I mean, for everyone you catch and put into quarantine who later turns out to be infected, you halve what otherwise will be an explosion. By now, 7.5% of the population has been in quarantine, some more than once. I've only been once in quarantine, but some in my hospital have been twice or 3 times. We've had successful tracking of over 70% of all infections, and we use also DNA analysis of the coronavirus. So, for example, now we have a phase 3 of the epidemic in Iceland, and through collaboration with Decode Genetics, we know that all the infections we have at the moment can be traced to 2 tourists who came into Iceland in August. One was, well, I won't say which countries they are from, but it's that doesn't really matter. But it you know, we can trace it that way even. Now, here's just a bit about the outpatients. So we wanted to provide continuity of care of all COVID patients, and we wanted to treat patients at home when possible, because you have to match the need of the patient to the service he gets. A patient who is not really unwell, even though he's got COVID, has no business being in hospital. It's just going to be bad for him and bad for everyone else there. So you have to be able to triage very early on and match and provide people with support still through telephone or through apps or telemedicine at home, and then bring them in quickly and safely if they need to. So we are triaged now. Like, for example, today I can tell you, because we're in phase 3 now, which came up back in September, that we have 680 people in our COVID outpatients. We discharged 100 earlier today. I can tell you that out of those, 22 are red, which means, sorry, 22 are yellow, which means they are not that well. And 3 are red, which means that they are in imminent admissions. And we've admitted 2 people in the last 24 hours. Okay, just going on. This is just to show you that you can see how this is the number of admitted patients at any given time, and they were about 45 at the top of the phase 1. And then now we've had phase 3 very recently, but we already see from our predictions, we've used predictive models which have fitted very well, and we can see that we are already on a gradual decline. So I think we are through the worst there, and we've been able to cope quite well. Just conclusions, 5 points or 4 points really. I think our take-home message would be: 1, it is so important to communicate clearly and openly with the public. It's very important to detect early, quarantine and isolate. It is very important to triage into appropriate services, because that's the only way we can cope. This is such a massive undertaking that you cannot afford to give people any more support than they need. That's the only way you can then cope and give the people who are really unwell what they need. And number 4, it's so important to keep an adequate stock of PPE and distributing it well. So the conclusion I would say is that politics will definitely not defeat the virus. I think the evidence from around the world has proven that. I think what can help us manage it is to use the best possible information and try to obtain an overview of facts. And then we have to be willing or humble enough to make decisions based on this. Thank you.
Thank you very much, Páll Matthíasson. And you will surely also receive a lot of written questions. Now we have to conclude, but first, because we have not enough time to ask specific questions, we only want to hear from you what are the 2 or 3 very relevant words to consider in relation with COVID crisis. And I start with Luigi and Luigi Aparo. I don't know, is he still with us? I think no. So, Gerry, please.
Yeah, I suppose there's a couple of things. Vigilance and ensuring that we follow guidelines, because as Páll has very clearly said, it's not going to be politics. It's all of us working together and working to a particular standard. And that is the one way as a community we can defeat this. I mean, it is going to be a significant challenge, but we must follow guidelines, particularly across Europe. We need to all follow guidelines and ensure that we adhere to them. I mean, I think that's the biggest message at this stage, because we don't know where we are on vaccine. Hopefully, we will have some breakthrough in the next 6 months to a year or whatever, but we just need to follow the guidelines, both in hospital and in the community. And get the education out.
So long 3 words. Thank you, Gerry.
Okay. So, Louise, please.
3 words, please. Thank you so much.
Sorry.
We can try to gather the main ideas. This is why the challenge for us to make it like a resume and like a challenging for the next, and make it easy for the people. This is the challenge. 3 words. Louise?
Yes, I think the solidarity and the collaboration, that we need to respect the different disciplines, you know, medicine, yes, but the most basic support for people. I thought Páll's triage arrangement was absolutely excellent, and we need to continue to engage with our populations to say that we are going to be living with this, and their role is just as important as that of the clinicians and the hospitals and our politicians also.
Thank you.
Matthíasson.
Okay, yeah. I mean, I agree with Gerry and Louise. I mean, I think communication and collaboration, both within the services, but also with the public to get, because they have to be willing to work with us. And then I would say a willingness and humility to face
I agree
the
with
truth.
that. Yeah. It's a nice word. Exactly. We need this.
Is there anybody other with us? I think the other speakers are no longer on the screen.
I would try to sum up even in French. Yeah. Vraiment, on a d'excellents échanges qu'on vient d'avoir tout cet après-midi-là sur les 3 panels, sur lesquels vraiment des expériences des différents pays nous ont permis de voir qu'au final, et je pense que Philippe et Marc pourraient compléter, on a exactement la même convergence, un devoir de réactivité, réflexion rapide, mais aussi comme ça se synthétise sur les 3 mots qui voilà, communication, que les gens puissent collaborer et surtout réfléchir au bien-être de tous. Et ça, plus on communique, et c'est l'affaire de tous ce sujet-là, ce qui rend, on le disait au départ, peut-être des process qui ont l'air simples, même une modélisation simple, mais leur mise en place nécessite la collaboration de tout le monde. Donc, moi, je pense que Philippe pourrait compléter un peu par rapport à ce ressenti-là, mais...
First, I want to thank a lot our European colleague to participate to this debate, and also perhaps one more word, it's anticipation, to try to have every time a time to be in our mind every time time before the disease. Mais sinon, je suis d'accord tout à fait avec ce qu'ils sont dit. Les mots-clés, c'est communiquer, c'est penser aux autres et c'est travailler ensemble. Et puis, oui, la seule chose que j'ajouterais, c'est l'anticipation. Il faut toujours essayer d'avoir un temps d'avance sur la situation et être capable de prévoir le temps d'après.
Okay, I see Georgia and Lajos are also on the screen. And I invite you to say also which are for you the keywords to consider.
3.
Yeah. Okay.
I don't know why 3, because trois in French means 3, but it could be nice to say 3 words.
Georgia?
Well, unfortunately, COVID-19 dramatically unveiled the fragile state of world's health and social systems. My conclusion, my voice is people first.
Yeah, very nice.
I think this is all about.
Okay, thank you.
Lajos?
Even in German, you can translate to be easier for him in Deutschland.
We don't hear you. Huh?
Can you hear me now? Hello, can you hear me?
No.
Yeah.
The sound is not good.
It's far. Yeah, it looks.
No, we cannot hear.
Yeah.
We cannot hear.
Can you hear me?
Yes.
Much better. Much better. Yes.
Also meine Konklusion ist, dass die Politik, die Wirtschaft, das Gesundheitswesen muss sehr viel aus dieser Pandemie lernen. Die Wege, die verschiedenen Länder gehen, sind dieselben. Kultur von der Wirtschaftsstärke.
The limit of the system.
Lajos, sorry, we don't hear you, but you can send us
nice.
your keywords by email, so we will consider them. Thank you.
Okay.
Perfect.
What is you? Okay, bye-bye.
Thank you. Thank you once again. It's really a pleasure. I think we are reaching the end of this 2 very nice and intensive exchange moment of 2 days for this first edition. I would to thank all the participants and attendees from in the place, but also the network. What we can do right now, maybe to have like a conclusion word and ask after all some people to come with us on the stage, please.
Just one quick visit. First, thank you very much for all the organizers, because it was a very, very big challenge to have this conference and a new kind of conference, half in presential, half by video conference, and bravo. So one thing, bravo, of course, I come back to COVID for all the people who in all the country in Europe, of course, but also in everywhere in the world, fight against the disease. And thank you very much for all the participants, all the speakers, because the exchange was very, very interesting. I have a lot of good comeback since the beginning of the conference. So I think it will be a good idea to try to have a new session, a new edition in the future. It's difficult to say no when, because the situation of the COVID and of the capacity of travel and so on is very uncertain, but I think it will be a good idea to have a new edition in a few months. Thank you very much for UTT and IHM and Hôpitaux Champagne Sud, of course.
Yeah, for sure.
Okay, thank you from me too for the invitation first to participate in this very interesting forum. Conference and maybe we have the possibility to organize a next edition together.
It will be a pleasure, really.
It will be a pleasure for us also. Thank you.
Merci beaucoup, merci à tous. Oui, on peut applaudir, on s'applaudit tous, mais c'est bien. Ce que je me propose de faire, c'est d'inviter Lionel Amodeo, qui a beaucoup travaillé, qui va nous dire un mot. C'est notre il va dire quelque chose en français et surtout ceux qui sont impliqués pour qu'on puisse prendre une photo avec un mix présentiel et digital. y compris ceux qui ont été en charge de la logistique. S'ils veulent bien se mettre, ça me ferait vraiment plaisir. Monsieur Kérémy, ça serait bien. Ah oui, oui, si on a bien mangé, c'était malheureusement à distance, ils n'ont pas pu apprécier. J'appelle tous ceux qui ont. Voilà, donc c'est ce qu'on avait deviné. Ouais. Et Nathalie, en présidente de l'IPC. Donc là, on peut remettre les masques. C'est ça les limites du système. Je me permets simplement de donner la parole à Lionel 2 petites secondes. Lionel.
Je pense que tu as tout dit. Merci à tous. Merci donc aux partenaires, hein, que ce soit les hôpitaux Champagne Sud, que ce soit l'Association européenne des directeurs d'hôpitaux et bien entendu l'ensemble de l'UTT, hein, avec toute l'équipe organisatrice. Alors, je ne vais pas me lancer dans les noms parce qu'on en oublie toujours. Et puis, félicitations à Farouk pour avoir décidé de cette belle organisation et puis de son bon déroulement. Et puis donc, à bientôt. Et bien entendu, le dernier mot pour toi, Romain, pour cette communication qui a débuté déjà il y a longtemps. Et puis, je pense qu'il va continuer avec YouTube, avec ce qui reste encore sur le site. Et merci à tous. Et puis, bon retour chez vous. Et puis, be safe.
Thank you all. Congratulations.
Well done. Congratulations to you all. Well done. Well done.